Hello, everybody. Welcome to our board meeting today at Humber Teaching NHS Foundation Trust. It is nearly Easter and every day we're getting more daylight, so good news. And there's a lot of really positive news on the agenda today that's come in since our last meeting in January, and others will tell you more about that. So welcome, everybody. Apologies for absence. We have one from Stella Jackson. And that's the only one, I think. So declarations of interest, thank you for keeping these up to date. Are there any additions or conflicts that colleagues would like to raise from the board that I need to know about now? No, thank you very much indeed. We've got the minutes of the meeting held on the 28th of January. Can I see if there's any corrections to those minutes? No. Any matters arising on the action log work plan? No? Okay, in that case, we will move on to our service. Oh, hang on. Should we approve the minutes? We should do that. Yes, happy to do that. Great. And we move on to our service story. And we have Rosie and Alison here today to talk about how we're strengthening our sexual safety and professional standards work. You're very welcome. I don't know if there's an executive director who'd like to say something before we hear from Rosie and Alison. Looking around. Karen.
Yeah, morning everyone. So really just to introduce Rosie and Alison, but I know we don't really need introductions and I'm sure they can pick that up themselves, but both of them are going to present to you this morning a bit of an overview of the collaborative work that's taken place between particularly the safeguarding team and the people at OT team in the sphere of kind of sexual safety. But I'm not going to steal their thunder, I'm just going to welcome them to the floor. So over to the two of you.
Thanks very much.
Morning everyone, and thank you, Karen. So yes, I'm Alison Meads. I'm head of people experience, and I've got my lovely colleague Rosie with me today, who is head of safeguarding. So I am just going to share my screen with me. We do have a presentation that we will go through with you, just a couple of slides. And it should take around about 10 minutes, and I'll cover the first couple of slides and then I'll hand over to Rosie. Just struggling, I've got the wheel of doom at the moment, so bear with me. Here we go. Okay, so can everybody see?
Yeah, we can see that. I think so. Everyone's got their thumbs up.
Sorry, yes, thank you. Okay, so we have been asked to share our story. Can you see my notes on there?
Yeah.
No, that's okay, it's fine. It's on my screen, it's not on yours. That's good. Okay, thank you. So yes, we have been asked to share our story and to give a strategic overview of how people in OD and safeguarding have worked together to strengthen sexual safety across the trust. So we're going to start with the why this work is important. So the why at the very beginning of the story. So from a national perspective, the Worker Protection Act came into force in October 2024. For the first time, this created a legal duty on employers to prevent sexual harassment in the workplace. At the same time, the Equality and Human Rights Commission published an 8-step guide for employers, and they also strengthened their enforcement powers. However, in the NHS, the Sexual Safety in Healthcare Charter came about in September 23, so this was a year prior to these laws changing. All NHS trusts have signed, and what this does is it gives us 10 principles to work to for assurance, really. It basically outlines a zero-tolerance approach to harmful and inappropriate behaviours in the workplace. So that the Sexual Safety in Healthcare Charter is the thing that we've signed up to, and that's the thing that we work to. So bringing these developments together, there is a very clear expectation on employers to act. But for us, this couldn't just be a compliance exercise. Early on, we recognised this was an opportunity to build on what we had and to go further. This wasn't about legislation or targets or numbers. It's about how people feel at work. Every single member of staff has the right to feel safe, respected, and heard. One of the first actions that we took was to add to our Be in Humber behavioural framework, and you can see the wording on the bottom of the slide there in blue, that it's about the challenging and reporting of certain behaviours. So as you can see, by doing that, we set out our expectations very clearly, very early on. We also launched a trust-wide programme to strengthen prevention, embed best practice, and ensure we create an environment where staff feel safe and supported. It's an ongoing commitment, but we think it's one that our people deserve. So I'm going to speak directly to the collaboration element of this story now. So we brought together the expertise of People and OD and Safeguarding to create one coherent, joined up response. We didn't work in parallel. We made a deliberate decision to align our strengths. Safeguarding bring expertise in risk protection and statutory duties. People in OD bring expertise in culture, behaviour and staff experience and employment law, of course. By bringing these perspectives together, we look at sexual safety through a people and protection lens, making it stronger and more holistic. One benefit is shared leadership and coordinated governance. We have one consistent organisational message and a single set of expectations. Collaborating in this way has resulted in more informed decision making, clearer pathways for support, and far more robust assurance. Because we look at issues together, we're able to triangulate information more effectively, identify themes earlier, and act with greater confidence. Ultimately, aligning in this way has enabled us to create a safer, clearer, and more supportive experience for staff. I'm going to move on now in terms of what has actually been delivered. What have we achieved so far? So we do have a genuinely comprehensive programme in play, one that meets our statutory duty and our own expectations. We strengthened leadership in that we've got myself and Rosie as sexual safety leads in the trust. And then we also have Karen as the exec lead, and she does hold us to account. We have governance in place in that we have the sexual safety group reports into the safeguarding assurance group, and we also have reports going to EMT, People and OD committee, and of course board. We do have risk assessments in place in all areas across the trust, and these are reviewed annually. And we have a sexual misconduct policy that is aligned to the national framework, and that was launched in September 25. That policy includes a simplified reporting mechanism via what we call the report it route. So it's very well known kind of email way of reporting any concerns. I'm going to stop there and I'm going to hand over to Rosie, who's going to take you through the rest of the slide.
Thank you, Alison. Yes, so I'll continue through this slide. And first of all, I'll touch on the specialist support. So we've worked really hard to look at the specialist support, the support we already had in place, and then where the gaps were and what support we needed. So our trust, just as some examples, we have the Employee Assistance Programme via VivUp, which offers the counselling and signposting services. We've worked really closely with our occupational health team and advisors. There's some really great work going on there in terms of the support available. So counselling, specialised therapy, trauma-based therapy, and also support regards to physical health needs. We've looked at the support we have with regards to our domestic abuse champions across the trust and our safeguarding linked champions. These are additional voluntary roles that support both patients and staff around domestic abuse concerns, sexual safety concerns, and that those pieces of work are really closely aligned. Ourselves as a safeguarding team, we are a team of professional clinicians. We have specialist additional training around safeguarding areas, domestic abuse areas, and that's, you know, an example of why it works so well as bringing it together with our workforce colleagues. We obviously have the support of our workforce colleagues there in terms of advice and guidance around the policy, the practice aspects of it, and any sort of workforce relations areas. So there's a wealth of support there, and we're continually reviewing this. This isn't something that we've reviewed once and left. We review this regularly in our sexual safety group and take feedback from people and look to source support where there are the gaps there. We have training available, so a big part of this work was looking at the training available. There is an NHS training module on sexual misconduct at work, which is has been launched across the trust and within our safeguarding teams and workforce. That is mandated because we are obviously involved more directly in that work there. We have a dedicated intranet resource, so part of this work we've looked at what is on the intranet page that is available to support staff who are affected or witnessing sexual abuse or harassment. And we've revamped that. It's a really good page and it covers a lot of information about what our principles are and what support staff can get. And then we've delivered in terms of oversight and consistent action via National Assurance Framework. So the Sexual Safety Group monitors this. And we look at the National Assurance Framework, and out of the 83 national actions that are set, we know that the Trust are rated green in 75 of these areas, 8 are amber, and importantly, none of these are red. So the amber work is around some of the stuff that we're going on to develop around data capture, for example, and we touch on that a little bit later in our presentation. All of our actions continue to be monitored, and every element is progressing as it should. So overall, we've moved from early planning to a place of real, measurable, organisational-wide progress, and the groundwork we've laid will continue to strengthen safety and confidence for all of our staff. Next slide, please. This slide touches on impact and early outcomes. So what do we know so far in terms of the work that we have delivered? Since implementing the programme, we've seen some real meaningful improvements across the organisation. Firstly, staff awareness and engagement has increased. Colleagues are more informed about processes and more willing to engage in discussions around those concerns. We're also seeing greater confidence in raising those issues. So staff now have more clarity about how the trust responds. And we're learning from cases that are reported, and every case and every situation provides really valuable organisational learning. A major benefit has been the strengthened links between key functions, so the links between reporting, safeguarding, HR and professional standards. We are sharing available information between our services, and that means that our responses are more coordinated, information flows better. We're now identifying issues earlier and escalating them more effectively, which gives us a stronger assurance and helps prevent problems from escalating. And finally, we know that these changes are reflected on national staff survey results. So we've seen a positive reduction in the prevalence of incidents, falling from 2.7% in the 2024 survey to 1.9% in the 2025 survey. So that's a really encouraging trend, and that percentage represents the percentage of staff who have been subject to unwanted sexual behaviour in the workplace. In addition to this, the breakdown of that allows us to look at prevalence within divisional areas and service areas, and also professions. So we can look at that data and we can really target down our responses and our support to those professional areas. Next slide, please. So what's next? Looking ahead, our focus is on building the momentum and maturing the programme further. So we'll continue to embed the programme across all areas, ensure it becomes part of everyday practice rather than a standalone initiative. Alongside this, we'll strengthen our assurance processes, and so we can more confidently understand how well the approach is working and adapt if we need to. A key element of this will be the further development of specialist training and the refinement of our policies. We're also planning to deepen our intersectional insights, so recognising how different staff experience sexual safety incidents and ensuring our approach is sensitive to those nuances. Finally, we'll be increasing the use of data and staff feedback to inform our actions. This is going to help us target improvements more precisely and track that cultural change over time, so that our efforts are meaningful and they're evidence-based. Finally, we'll be maintaining visibility and leadership commitment across the trust, and that's crucial. We'll keep the programme prominent across the trust, and it'll be supported by ongoing oversight from the board to ensure continued accountability and momentum. Together, these are the steps that will position us well to strengthen our culture and sustain the improvements already underway. Next slide, please. So we wanted to finish on some closing thoughts. Essentially, what we want to show today is that this work goes far beyond meeting our compliance requirements. At its core, it's about shaping a culture where every staff member feels protected, supported and confident that the organisation listens and responds where concerns are raised. Our aim is to create an environment where people feel safe to speak up and know that their voice genuinely matters. a key driver of this progress has been the strong collaboration between safeguarding and our people on OD services. By bringing these functions together, we've strengthened the trust foundations, we've aligned policies, we've improved responses, and we've created joint process that supports both staff wellbeing and organisational learning. Together, this partnership has created the conditions for long-term cultural improvement, not just short-term fixes, but meaningful, sustainable change in how we work, how we support each other, and how we uphold our values. And I think that is us, which leaves us open to questions and comments. Thank you.
Okay, thank you very much. If we can just clear the slide deck before we open up for questions and comments.
I lost you there for a moment. I'm just going to stop sharing my screen.
Thank you. Great, that's brilliant. Okay, right. Just before I bring some other people in, I just wanted to just flag is particularly for any of our staff who might watch this. I think just to acknowledge that sexual harassment has been illegal for some time. It's been in various bits of legislation, in Equality Act of 2010. And the reason why I think the legislators decided to improve that was because there's a sense that actually, despite a lot of effort, it's still ongoing and it is still a major issue. And surveys of staff across the NHS have shown that often people abuse their position of authority and power to carry out this sort of behaviour. So I think that's really quite important to acknowledge that this isn't something we've just become aware of. I know we haven't at Humber in the last couple of years, but just to commend you on the really broad range of work that's being done. The second thing I just wanted to just flag as well is, of course, it is about our staff and how our staff treat each other, but of course it's about our patients as well and protecting them from sexual abuse too. And in recognising that sometimes our staff are on the receiving end of it potentially from patients. So it's a very complex dynamic here in terms of people's roles, positions of power or vulnerability, I think, in an organisation. And before I pass over, I just wanted to just maybe in answering the questions, you don't have to answer me straight away. I suppose I'd like to know a little bit more about what so far you've learnt about the response from staff, and that includes where maybe it's not been as great, and what you do when a staff member raises an issue of sexual harassment when they're in a working place with the person who they're alleging is doing this. How do we manage that situation? Because I think that's really difficult for people in that environment. Any other questions for comments from members of the board? Kath.
Morning, Rosie and Alison. We've not met. I'm Kath Smart, a new non-executive. Nice to meet you both. My question was kind of connected to yours a bit, Caroline, I suppose, because I'd looked at the data you've put up around the staff survey, and obviously we're considering some of that later on the agenda, and you've got a commendable improvement in there, which is way below the benchmark and is reduced down to 1.9% in the latest data we've got. And I think you said on your last slide, you said you're going to start using the data and the staff feedback to do that targeted improvement. So it's kind of on the lines of Caroline's question around that qualitative information that we can have from staff who've had to raise a concern and go through the process. Are we able to, use that in order to drive the improvement? And what is the positives and the negatives? I suppose it's very similar to Caroline's question, positives and negatives of that qualitative data, because the staff survey gives us that quantitative, we are making an impact, which is great to see. And I suppose it was the qualitative impact then I was after.
Thanks, Kath. Rosie.
Yeah, I don't know if you want me to come in and just try and give a response to some of that, because I can provide you with that. Just in terms of one of your questions around what do we actually do, Alison touched on the policy, and within that policy there's a really clear sort of process within where a sexual safety concern is reported, what happens. We have a function within the trust now which is Sexual Safety Review Group, so where there is a report through of a sexual safety incident and it meets that criteria, the review group convenes and looks at the concern, the disclosure. We look at what actions we need to take formally, but also, and most importantly, what support those affected are who do need. And that's something that we'll keep reconvening as things progress. So that there's a really clear process there in terms of what do we do, and it brings everyone relevant together. So that's ourselves, it's people from workforce, and it may, you know, it may bring other services in depending on what support and the particular nuances of the case. In terms of the learning, I guess we could feedback one of it. We touched on the staff survey feedback and the results, and one of the feedback that Alison and I have had is around that some people, as much as work we do around raising awareness and opening those doors, some people do still feel more confident reporting anonymously, so we've worked with our Freedom to Speak Up Guardian and ambassadors, and there is now a reporting route through Freedom to Speak Up as well as the reporting mechanism, and that just means that we've got other options. So for people who don't feel confident reporting and coming forward with their identity to us, we've got a really clear route for anonymous reporting, and that's come from the data and the feedback that we have got so far through it. So that's just I think one example of how we take people's experiences and develop our practices going forward.
So what's the situation where we have someone who raises a complaint and it's against someone in their unit? How do you manage that?
We have the benefit of having a safeguarding and workforce aligned sort of approach is if we have someone who is in a position of trust, working within our organisation, within the safeguarding, there was policies under safeguarding around allegations against people in a position of trust, and again, that is where the right people convene, look at the allegations, disclosures, think about what's happened and what action needs to take. We think about the safety of our staff and our patients within that mechanism. The sexual safety review group it mirrors that, and that's where a person who may not be in a position of trust but is still an employee, and again it brings people around there and we'll look at the allegations. So it might be there's some actions that come from that around immediate safety of patients and staff. Do we need to go down employee relations, workforce elements with it? We might liaise with specialist support services for that particular person, depending on again on what's happened to them and what their needs are. It could be psychological support, physical support. We might liaise with our partners, and that's a process that tracks through. So we look at, monitoring what actions need to happen, and we follow that right through to the end till there is a conclusion.
Okay, right. I'll maybe come back to that offline on that. Steph.
Thanks, Caroline. Just to develop your point a little bit more about patients. Obviously, some of our patients, or many of our patients, are vulnerable in multiple ways. And one of those ways is around sexual safety and how they interact with others at home, for example. I know that we have very strong safeguarding systems in place. We have really good training for our staff around safeguarding. But could you perhaps just explain a little bit about how we would deal with an incident of where we've got sexual harm taking place with a patient, and how we support staff in terms of the training around that and how we do our learning around that?
Where a patient has experienced sexual harm, just to clarify. Yeah,
not necessarily
absolutely.
from as a patient, as part of their background as a patient, as it were.
Absolutely, yeah. Okay, so within our safeguarding processes and training, we have our staff are aligned to certain elements of training, and within that training, we do explore sexual safety, we explore sexual harm and sexual abuse. So we are upskilling our staff to understand and recognise what sexual abuse and harm is and how to respond. Within the trust, I have a safeguarding team, and they run a duty team that supports our staff. So where there are concerns raised about the patient, there's conversations that are happening, and we think about what's happened to that person. We speak to the person, the patient, and understand what their experiences are and what they'd like to do, because it's really important that they're empowered throughout the whole process. Examples would be that we might link in with the police where sexual assault a harm has happened, and that counts for historic allegations as well. So we're getting quite a lot of patients who may have experienced historic sexual abuse, and we're supporting them with those elements. We look at the support they need in terms of physical safety. So we've got really close links in with our physical health services, sexual assault referral centres, just looking at those elements, and also our psychological safety, really understanding that trauma response there and what support we need for the patients. We obviously make safeguarding referrals through to our local authority in line with our statutory duties.
Thanks, Rosie. That's really helpful to understand.
Okay, Karen.
Yeah, just a couple of things from me. And just to come back to your point, I think, Caroline, originally in terms of the action that we take. And I think it's important, I know we can certainly have a conversation outside of here. In terms of the most recent cases that come to my mind in this space, I think the review group's really important and each case is looked at in terms of its own merit. However, suspension and full and thorough investigation is often proportionate in these instances, and that is an action that we as a trust do take. I think what we have is the additional strength of the review group that maybe doesn't exist with other types of casework, maybe where at a kind of a manager leadership level, a risk assessment will be undertaken and the merit of the case will be looked at between HR and the individual manager. I think to Rosie's point, the review group has a very rounded set of specialists that sit within it to kind of look at that case so that we can make sure that we're managing all aspects in the right place, whether it's support, how we manage an investigation, and so that we can ensure that holistically all of that is looked at. But proportionately, and like I say, in recent memory, suspension has been proportionate to keep staff, patients safe and to allow for an investigation to happen as appropriately as it can under the circumstances. So I just wanted to pick that bit up just to kind of complement the things that Rosie had already said. But go on.
I know, I agree with that. I suppose that, look, there's a lot of processes and they're all really important. There's lots of groups, but having worked in this space myself within local government and elsewhere, and for a trade union actually too, I suppose I'm trying to, just get across, and particularly to our staff and others listening, that if something happens that causes them to feel that they are on the receiving end of various forms of sexual harassment and abuse, and it can take many forms, I suppose what we want to know is that we want to build the confidence that they speak to somebody and that person is their line manager and that line manager acts on it. And I suppose down the road, it will be interesting to know more about how many of the members of staff or even patients being affected by this, how long it took them to raise it and why they didn't raise it maybe in the first instance with their line manager, or did they raise it with their line manager and it wasn't acted upon. I suppose down the road, that's what we really want to be able to understand, because the first point should be the line managers should be seen as open and supportive to staff. Whatever other organisations and groups are meeting and what happens, that should be that you would want to encourage that as a conversation. And obviously that's not going to be, it could be a line manager involved in it. That's not always going to be the right route. But I think it's just having that understanding of, that point at which someone needs to talk to someone, that we've got a culture that is embedding that sort of trust to do that.
Yeah, and I think that's a really important point, and I think that's why we built on the groundwork that we'd already set out as part of the Respect campaign. And when we look at the staff survey of 2024, it told us that was the biggest sort of leap in terms of positive improvement around safety culture and people feeling safe to report incidents, bullying and harassment. So we fundamentally stepped onto the Respect campaign and enhanced that around sexual safety, because we knew we had the fundamental culture in place and that we could build on that. So that's why we have made the decision not to distinctly separate this out from things that we have already nailed fairly well in the organisation, because ultimately it's our culture all the way across, isn't it? And I think that it was really important for us that we could build on what we'd already achieved and part of our successes, and I guess that's why this has landed so well in the organisation. Thank you.
Okay, thank you for that. Michelle and then Sarah.
Yeah, first of all, thank you for the presentation, Alison and Rosie, really helpful and great work. So thank you for that. It is appreciated, because you're a very small team as well. We need to remember that, and this is everybody's responsibility. I think Karen has mentioned a lot of what I was going to say about the platform and the work that we've done around the Respect campaign, and it's good to see that slow progress in the green shoots in relationship to the staff survey, etc. But we've got obviously lots of other avenues as well to continue. We do involve the police if we're required as well, just to emphasise that. So we don't not do that either, and we do encourage that wherever we can and support that process. And there's lots of both psychological and pastoral support available to staff as well that we do. Sometimes it's not always appropriate, the line managers, so hopefully we have and we direct staff into other methods. I think it was briefly mentioned around Freedom to Speak Up, going direct to the safeguarding team. So we do have some other direct routes as well, rather than just going through, because sometimes that's not appropriate. And I think we do need to continue to build on the respect, but I was saying it all links into the cultural work that we're doing around being Humber, the behavioural standards, appreciatively calling it out, being assertive in relationship to that. And I think the more we develop the being Humber cultural piece, the more we'll continue to drive this agenda as well, that is so vitally important to us all. So I think that's really important, and that's why it's really all the way through what we do, because this is a really important fundamental aspect of that, but it does link really intrinsically into those behavioural standards. So that was the first thing. The second thing was just from the team point of view, really. If there's anything else you needed from the board, you've got us all here. And if there's anything else we can do to support, I know we ask this a lot at the exec management team, but we are the board. There might not be, but if there is, I'm sure you can come back and ask us. I'm sure Caroline is available as well. We will take a few things offline. But is there anything else you can think of today? I'm not putting you on the spot, honestly. It's just if there is anything, now's your opportunity.
I just want to say thank you for that. There's nothing I can think off the top of my head, but I will give it some thought. But thank you for that. That's great.
Thank you. Sarah.
Yeah, just very briefly, and Michelle mentioned the bit that I was going to say around the kind of police involvement as well, if that's required. And the other bit I was going to mention around that PIPOP process is that if there is people that are registered with professional bodies as well, we also ensure that we are making the necessary referrals to the professional bodies as well as part of that process, and that links in with our HR processes and also our PIPOP process as well. But that was it. Thank you. Great presentation, team.
Thank you very much. That's the end of the questions. Thank you for that presentation. I think down the road, maybe some more qualitative stuff will come out that we can hear about. But that's a work in progress, and thank you very much. It's important. It's a shame today in 2026 we're still having to deal with the level of violence against girls and women in the workplace and outside of it. It's not acceptable, but I think you're doing a great job, and so are the others involved in this as well. Thank you.
Thank you, Chair.
Right, okay, we move on then to my report, in fact. So I've got a few things that we need to well, one thing to approve, but also just to be aware of today. But first, and I'm not going to steal Michelle's thunder, since we last met in January, there's a number of different things that we have been working on as an organisation, but also as a board as well. So just to say thank you to all our staff, to everybody that's been involved in some of the outcomes. We've literally, wait for a bus and then 3 come at once, and it feels a little bit like that recently. Not only have we got our green capability assessment, which is great, we're into segment 1 from segment 2. We've our operating plan, which we put the first submission in at Christmas. We put the second submission in on the 12th of February. We had a tiny smidgen of an adjustment that was really small to do in the last week or so, but that's gone in as well. And it's a real credit to everybody, all our staff and others who've worked on that. But also I have to say thank you to the board as well, because I think every member of the board, particularly the executive directors, have been working their socks off on this. But I won't say any more about it, but it's a big thumbs up from me for all of that. So thank you for that. I just, I did flag in the report, sometimes I think it's just important as well, in all this discussion around finance and everything in the NHS, I think it is just worthwhile just acknowledging, and I have done this in my report, whilst there's more money might be coming into the NHS and we benefit from that as well. The Secretary of State does an annual report to Parliament on the spending plans, and for 26-27 for mental health care, as a proportion of the money allocated of NHS spend, it's forecast to be 8.4%. Now that's lower than the 8.71% planned for this year. And that's quite important because there's a lot of conversation about parity of mental health services with physical services, and we're not there yet. We're not there yet. And I think it's fair for us to acknowledge that, and in our conversations when we're trying to protect monies like the Mental Health Investment Standard and so forth, that we are mindful of that and make sure that those who make the decisions are also mindful of that situation. But it is as it is. Now, as you all know, Dean Royals left us earlier this year, and I have a paper on the agenda. Oh, Steph.
Yeah,
Sorry.
Caroline, I think I need to declare an interest in this, so I'll leave the meeting for a short period.
Okay. So the reason why Steph is leaving, because the paper is all about her. So the senior independent director is something that we have to approve as a board. Since Dean has left, and he was the former senior independent director, I've taken soundings by a number of people. It's in the paper. I'm not going to repeat it. And I would like to ask the board to approve Steph as our new senior independent director. Can I see all those in favour of that? Great, lovely. I don't. Someone just mentioned to Steph she can come back in now. That would be great. The second issue I just wanted to flag as well is in light of some of the personnel changes within the non-executive director team. I've done an outline of the committees going forward. We have got some new non-executive directors coming onto our team, but I've allocated sort of, if you like, those positions within the committees, and I hope I think I sent it out to all the NEDs in advance anyway, and everyone was quite happy with that arrangement. We can always keep it under review, the committee membership, the chair membership, and of course the champions and other roles as well. And if any of the NEDs, obviously, there's issues with the workload or you want to change, you can come and speak to me directly about that. So that's really just for noting. So thank you about that. And also I'm pleased to say, just to flag as well, because I think it's important to flag it, is Phil Earnshaw, Dr. Phil Earnshaw, is going to be the resident doctor NED, and that's in line with the 10-point plan, which I think there's been some terrific work done on that, Kwame and everybody involved in that. And this is one of the areas we can green light now that is also in place. And thank you, Phil, for assuming that role as well. Also, just to update, when I wrote the report, particularly around the committees, I mentioned about the associate hospital managers. And again, Kath quite rightly pointed out to me, Catherine Smart, our new audit chair, is a trained associate hospital manager. So actually, as well as Steph and Phil, who are also trained, Kath is as well. So we do have a complement of 3 non-executive directors who are trained, which fulfills some of our requirements in terms of the guidance from the centre to give us that insight, I think, more insight into the board of that particular work that is really important. So I'm really pleased about that. And as the new non-executive directors come on, we'll see about training some of them up as well. But Kath, that's great. You've brought with us that particular training and skill, and we're really appreciative of it. So thank you very much. Any questions? Nope. Great. Okay, we'll go on to the Chief Exec's report.
Kath, did you have a question on that?
Oh, sorry, Kath.
Yeah, it was just on another part of the report, Caroline. So I note the NED and ED visits, and they are also in Michelle's report. And obviously, it's really good practice to have that leadership visibility and for NEDs to understand the services the schedules on the way out. I just wondered, from a feedback point of view, what comes out of those visits back to teams and services or back to the committees or anything?
Michelle?
Yeah, we get the summary reports into the exec management team, and then we'll do a little quarterly update in my report to the board. And if there's anything that comes out, it goes into the relevant committees. And obviously I feed back to Caroline if there's anything, or Caroline feeds back to me if there's anything. So that's where the visits go. Because obviously the exec team do a lot of visits. Obviously we pick out some of them on this report. We have a standing agenda item on the exec team about visits, anything that we've done, because sometimes we just pop into places, etc. So we always have something at the exec management team every week.
And that would be
And-
sort of positives and negatives.
Oh God, yeah. I know, I'm more interested in people that know very well the negative piece. Really, to be honest, I do like that balance, but we need to make sure that we're looking at where we do need to make improvements and we're cited on it, because it's about being cited on things, not necessarily getting into all the operational detail, but it's about being aware, and being aware that they're being carried through.
Yeah, I was just trying to see that what the loop would be, so
Yeah.
that's helpful. Thank you.
Yeah.
Just to say, Kath, before I bring in Steph, is as chair, I should be getting copies of the visitors, the report forms that come back as well. And so we need to make sure the board support unit are doing that and that goes on the visits. But also the board support unit should be actually pulling together, I think they are, Michelle's trying to sort this out, is a number of new unannounced visits that should be planned as well, which usually involve a non-executive director and an executive director. Yeah, that should be getting sorted out, I hope, very soon. Steph and then Phil.
Yeah, after each visit, we complete a visit form which highlights some of our observations, positive and negative, around. To be fair, mostly the risks any risks that we identified or negatives are already well known to the teams that we visit, not surprisingly, which is quite reassuring. But yeah, and that gets fed in via the board support team for the non-exec visits. So we try to be as thorough as we can with that feedback.
Phil.
Yeah, just really briefly, just to say that the first tranche of unscheduled visits came out yesterday.
Oh.
So we're on with that. So I think I'm going to Town End Court. So that's one that I wanted to go to see.
Okay. What I've asked the board support unit to is actually sort of look across all the visits so we get a good spread across the different services. And you know, because otherwise we can end up with certain services getting lots of it. We've got to make sure that there is a good spread. And I've asked the board support unit to make sure they're managing that as well. But yeah, I missed that email, Phil. So thanks for flagging that. Okay. Kath, if you want to talk to me about visits also outside and about planning them for yourself and everything, happy to do that. Okay, let's move on to the Chief Exec's report. Thank you. Thanks, Kath, for raising that.
Yes, thanks. And just to finally on that, one of the things that we don't do, Kath, at the visits, and I'm sure that you won't. It's not an inspection visit; it's a knowledge visit as well. It's about you getting to know the services, because one of the things when I did them in the past that the staff were really complaining about, that they felt they were being inspected, and it wasn't that really good relationship, because we're trying to build that relationship up between the board and the staff. That doesn't mean we don't want you to notice things and knock them down and bring them back if you know some of it's how we do that. And if we need to give you any support in relationship to how you do that, then we're happy to do, because we want that balance, but we want it to feel more informal, if you know what I mean. So we'll get more out of the visits. So okay, thank you.
Got that. I think you've got that from, she's been a NED in the NHS for a while for that. Before they've done that at Doncaster Bassett Law as well. Okay.
Yeah, just remind folk, but that's good. Okay, so on to my report. So good morning, everybody. Thank you. There's a lot in my report, and lots of, obviously, from the directors themselves can chip in. There are some policies to approve, as always. They're on the front sheet. Thank you for picking up the visibility piece. We do try and put a more as an overview of where we've been, but there's a lot of work goes on in relationship to the execs, particularly getting out and about, and also the general managers, etc. I've picked out the Excellence Awards just to give you a list of what we've submitted. These are the first time that the NHS exec has done Excellence Awards within the services. Very similar to HSJ, I think that they're going down that route, but they want to own it themselves. So just to give you a breadth of some of the things that we're working through and that we've got clear evidence on as well, because obviously it's about evidence-based as well. So they're listed there, and I thank everybody that has put in, and we could have put more in, but I think they're the top ones that we will look at, and I think the board has started on a lot of those. We'll pick up the medium-term planning later, but we did get some feedback, very slight feedback back, but other than that, everything has gone through, and I thank the team in relationship to that, because that's been a bit of an ordeal. I've put in about Easter, because believe it or not, it is nearly Easter. I've got absolutely no idea how we've managed to get to Easter this year. It is flying by as always, but we're doing our usual competition. creating Easter bonnets and decorating egg. Obviously, we'll do that for service users, lived experience, our staff, etc. But we're also, as a thank you to staff, because Humber does things differently, and we are sending out our little vans to give out either Easter eggs or ice creams. I know it's not particularly the ice cream weather, it was a couple of weeks ago, but we are giving options to staff as a thank you for all the work that they've done over the winter period and etc. So that will go out from the board. Caroline has mentioned the National Oversight Framework. So as we've talked many times in our strategic meetings, this is an oversight framework for all organisations, and we get put into what's called segmentations, 1 to 4, well /5 now. Well, I'll come on to that. The lower the number, the better. This allows us to have a little bit more autonomy ourselves in relationship to how we do things. Hence, being able to give out the Easter presents, etc., to staff. So we're now the last quarter, and I'm very pleased to say, as Caroline said, that we've now gone into segmentation 1, which is the top level. We will continue to look at that and to improve that. We were never ever complacent in the organisation. We will continue to raise our standards. We've got some great services and great staff, and it is a team effort, but we will continue to develop those services. And we're 7th out of 61 trusts at the moment. So thank you to everybody that's been tirelessly working. Basically, we have no community waits over 52 weeks. We've got the lowest percentage of our adult acute mental health units who have a length of stay. So we've actually got a very, very, very good length of stay, and we don't have a high readmission rate. So, because sometimes you can say, well, you've got a low length of stay but high readmission, that's not good, but we don't have that. So that just shows that the pathway is really working. And also we've got quite a low bed base as well, so it demonstrates that that community aspect is working very well. Urgent and response rate, as you know, that 2-hour response rate was 97.5%. and our finance position is favourable. So they're the key things that they look at. So I'm very pleased to say that that we are segmentation 1, but we'll continue to work through that. There might be some metric changes for the next year, but we're working with the centre on that. I'm working with NHS Exec and with NHS Alliance, nearly said Confederation, NHS Alliance, on what they need to look like, both for the acute sector and for mental health and community. Care Quality Commission, and that's on the agenda, so I'll leave Sarah to take you through that. And there's lots happening around personnel changes around the system, which I've hopefully incorporated. I'd like Lynn just to give you a bit of a brief on the changes to the CPA, because I think that's quite important. If you don't mind, Lynn, just picking up that, it is in your report. The Mental Health Nurses Day, I thank all the mental health nurses. That's on the 21st, and we celebrated that really well. I know every professional group and everybody that we do is really important and provides good patient care, but we did celebrate the 21st of March, and we've got social work weeks and various other things. Job evaluation process is working. If you remember, we mentioned that in the strategic meeting. Lots, I'd like Karen just to maybe pick up very briefly the software that we're purchasing, if that's okay. Mental health legislation, we requested a little bit of an information on that. That's concluded in the report from our medical director, and a very detailed digital report. I could go on because there's tons in the report, and I thank my colleagues for that. But they're the headlines I'd like to draw to the board's attention today. Obviously, we've got the charity report and our communication profile. But if you don't mind, Chair, if I could just hand over to maybe Lynn, just to give us anything from an operational point of view. But if you don't mind, Lynn, just picking up that CV, because I think it is quite a big milestone change, if that's okay. But yeah. Thank you.
Thanks, Michelle. Yeah, so just on the operational position, I think as you can see from my report, it actually shows that during the last couple of months, our operational pressures have been quite stable overall. Certainly, and that's been the case sort of definitely in the North Yorkshire system too, where the acute hospitals haven't sort of reached that Opal 4 position. It's been predominantly Opal 3. A bit more pressured on the sort of North and South Bank position, but again, not to the point where we have been sort of impacted by that, and again we've been focusing on our support to the rest of the system too, making sure that we are responsive to those ED referrals, etc. Michelle's already talked a bit about our pathways are actually working fairly well and being optimised at the minute. Just on the personalised care framework, as the update says, we've been waiting for quite some while actually for guidance nationally around the replacement of the care programme approach. So we did receive that last year. It is the personalised care framework, the modern approach to CPA. So we are taking that forward through sort of task and finish group work. The update sort of says really what the core principles of that is that we're introducing into our services, moving away from that sort of bureaucratic administrative approach to CPA, which is what it had become, where some service users sort of reached the threshold, some didn't for the care programme approach, as was, to this personalised. And I guess that is the sort of essence of it really. What we should expect to see is that everybody's care and support plan, you know, reflects their needs in a very personalised way, the expectations around co-production of service users in that care planning approach. The metrics that had been applied to old CPA, again, were very administrative, really, the number of reviews sort of taking place, to a more qualitative approach. There aren't any national KPIs being attached to this at the moment, which is interesting, although I do think, as Michelle sort of alluded to earlier, the National Oversight Framework, I think, is moving to that more sort of qualitative approach. So we know there's a potential around outcome measures, for example, sort of replacing that did it happen? Well, you know, actually, what is the outcome for the service user? So probably more on that as that gets finalised. As well, safety assessments and formulation, a key part of the principles still as well. So we have joined this work up with that work that we are doing on outcome measures anyway. So the clinically reported measures, the patient reported measures and experience measures where they apply as well. So we do have a detailed project plan that's being supported through our transformation work to make sure that we implement this well and we can evidence the qualitative changes sort of through that process in line with the guidance. And if there are national metrics that are applied to this going forward, then obviously we will incorporate that in our reporting as well. So happy to pick up any questions on this, but we do know when we compare to other trusts as well, that we are taking a systemic approach with this, sort of early adopters, as it were, of making sure that we've got a robust approach to implementing it. Thank you.
Okay, any questions on that? I've got one. Any others from board on that particular part of the Chief Exec's report before we move on to, I think, Karen? So I've got one on this. I mean, I presume one of the issues around the writing of these care plans is making sure they're accessible to be read by the patient or their family as well, because sometimes they're not written that. I think you're saying that between the lines. I'm literally putting it out there a bit more strongly. Sometimes, you know, people are used to writing things in a certain way in the NHS that is fine for professionals. So what work are we doing with those who are involved in writing these plans to maybe get them to think about how they go about this, so it's meaningful to patients and their families if they want to read them, and for other people to understand them down the road?
Yeah, that is the essence of the work, Caroline, and is the difference. CPA never was intended, but it ultimately became more of a administrative, bureaucratic process. If you were to read the care plans, unfortunately, they were often written in what I would describe as professional language and therefore weren't as accessible to service users and their carers and families in the way that they should be. And so absolutely the requirement is that these are written in the way that the patient and the carer and the family do find accessible. So obviously we have an electronic patient record. What we're working towards at the minute is how do we make sure that the patient, carer, family views are reflected in that care plan as well. So mechanisms are being developed to make sure that we can evidence that happens, and obviously that will be auditable through our sort of record keeping processes going forward as well. So it's been an incremental change, not that we haven't been working anyway towards that personalised care plan approach, but I think the new guidance really does make it absolutely clear that this is a requirement going forward and not something that is a nice to do, that it's a must do, and staff have to adopt that way of describing. So I think it's fair to say that when we pick up care plans sometimes, you know, it is, you know, easy to see that staff have written those in a language that, you know, we would see that needs to be improved. It needs to be written in the way that the patient understands it and it makes it relevant to them.
Okay, Kath.
Hi, yeah, it kind of links this agenda item and one earlier in Lynn's report. Am I okay to pick that up now?
Yeah.
So I suppose it links to care planning, but the patients who are clinically ready for discharge, which is on page 8 of the report, where Lynn has outlined some of the challenges faced with patients who are clinically ready for discharge, but may not have had that placement ready for them. So they're technically kind of delayed in our services. So there was kind of just 2 questions, because as part of effective care planning, we all know that the patient's future is always kind of kept in mind about where they might need to go. So that forward look around where they might, you know, what specialised placement they might need to be in would be a forethought as part of the care planning. So I was just trying to get a sense from this how much of this delayed discharges is still within our gift to influence and get our processes better or slicker, and how much of it is actually sat with we haven't got enough of those specialist placements available somewhere near our patch. Because it talks about the multi-agency discharge event, which is recognised as best practice in order to kind of scrutinise that. I was just trying to get a sense of, is there any of this within our gift, or are we saying actually we're doing everything we possibly can to plan for a patient's discharge out of our services as soon as we can, and therefore all of these patients are actually waiting for a placement and we can't influence that any further? That's the question, Lynn. Do you want me to phrase it any differently?
No, it makes sense, Catherine, and you can tell me in my response. So the whole point of the MAID methodology is it's very methodical. So for every inpatient ward, every week they have to demonstrate that they have reviewed every patient, no matter when they were admitted, and ideally from the day of admission or even before admission on some occasions. What is the discharge plan? What is the outcome for this service user from their inpatient episode? Because that should be thought about as early as possible. So the MAID process, actually the wards have to demonstrate that they've been through that process and they have to report it as well, so we don't miss a single patient in that process. Then as soon as obviously there is a destination that is appropriate and has been identified for that patient, then at every step is what's being done that we can do within our gift to ensure that we access that right destination placement as soon as possible. So some of that, quite rightly, Catherine, is in our gift. It's about how we are working with our other agencies, often social workers, for example, around securing those placements. Some can be straightforward tenancies with local authorities, and some, as you say, are more complex, complicated, specialised placements, you know, but not provided by the trust. So, and actually there is an escalation process built into the MAID process that as soon as we start to see an inappropriate delay in accessing that placement, there is escalation processes built in where we bring senior partners, increasingly senior partners, to the table around how we actually expedite those placements. So we apply MAID constantly, and you'll see in the performance report we've had some real success around reducing our delayed patients, but unfortunately it does vary from month to month as well, which is why the process needs to continue to be there, and we have that sort of robust oversight of it. So it's actually led day to day by the Deputy Chief Operating Officer. So she actually holds the MAID meetings. So we are holding our own staff to account for those processes in those inpatient areas on behalf of those service users and their carers. So it does relate, as you say, to the modern CPA, because the patient and carer involvement in that discharge planning process is absolutely key as well. So, you know, patients need to understand, you know, they'll have their own views and considerations in terms of what they want that discharge plan to look like as well. So the two should work hand in hand.
Yeah, that's really clear. Thanks, Lynn.
Good, happy with that, Kath. Right, great. Karen, did you want to flag some issues, and are there any other executive directors who'd like to flag? If you could put your hands up so I can see you in the sidebar box. Karen.
Yes, so I'll very quickly, as Michelle mentioned, just touch upon the job evaluation readiness, particularly in light of the Band 5 nurse role profiling reviews. So we did receive a national letter back in February outlining a very clear expectation around NHS organisations undertaking a review of all Band 5 nursing roles. And I think it's important to stress at this stage that we'd, again, already kind of delivered some underpinning work prior to that, where we had reviewed Band 2 to 3 roles, and to ensure that those healthcare support workers were operating within the remit of their profiles, and made the necessary interventions as we needed to as a trust. And equally, that was extending into nursing roles as well. And Sarah and I are both kind of very well versed in terms of the work that was underway. However, this shift was to specifically look at individual Band 5 nurses and the roles that they're undertaking, so that we can have assurance as a trust that we can respond appropriately, dependent on what those outcomes are. Now, we are still awaiting formal national guidance about how to do that. And I think in this space, given that the unions are working with us on this, and we've got a very collaborative group of staff side at this trust. But what we don't want to do is create any kind of variation in terms of what other trusts are doing as well. So we are awaiting that national steer. But what I can say is that the foundational work is being done by our teams in terms of collating job descriptions, ensuring that we've got the profile set up, looking at it from a working group lens, so making sure that we've got sort of multidisciplinary team type approach to looking at it, clinical experts, people from the nursing and quality team, HR individuals as well. As per kind of some of the expectations set out, we are completing a quite a thorough job evaluation audit at the moment that will be submitted nationally. So we're investing a bit of time in that at the moment. But like I say, we want to just make sure that we've got all of our foundational work in place, and then we will pick up that work at pace once we've got a greater degree of sort of insight in terms of exactly how we need to deliver that piece of work. I think building on that, Department of Health and Social Care, NHS England and NHS employers are working in partnership to procure a national job evaluation system. Again, at Humber, we already do have a local job evaluation system that we use, and we've got really good job evaluation practices at this trust already. So a great degree of assurance in terms of how we deliver that at the moment. However, the market testing has been completed and the procurement exercise underway. We're expected to get a preferred supplier identified at some point later this year. So I'll update the board as appropriate as we go along. Thank you.
Thanks, Karen, for that update. We did obviously, as in my report, discuss this at the last strategic development meeting. So thank you for that update. And it's good to hear that we're doing good working with staff side representatives. Have we had much in terms of inquiries from the nursing staff who may be affected on this particular issue?
No, we haven't, okay, Caroline, and we did expect that. But I think our communication was really clear that we would be very transparent. As soon as we had information, we would share it.
Brilliant. That's great. Thank you very much. Kwame.
Yeah, no, I wanted to bring to the attention of the board about the Monitoring of Mental Health Act, which report from the CQC. I have done a detailed report which will go to the Mental Health Legislation Committee, and I've briefed EMT on that. CQC has identified 5 areas which are challenging for mental health service. This includes rising demand and acuity, workforce challenges, inpatient environments, restrictive practice, and unequal practices. And I'm sure board members have seen that in terms of how we are addressing these in different committees and different reports to the board. I've highlighted some of the work that we're doing on that, especially including our equity care culture work, PCREFT work, which is trying to address health inequality. I'm sure that once we have done the detailed conversation in mental health legislation, an insight report will come to the board on how we are addressing these challenges which CQC has identified nationally. Thank you, Chair.
Thanks for that extra information, Kwame. Anybody else from the executive management team? I know there are other papers on the agenda dealing with some issues that they'll be speaking to. Any other points or comments or questions from members of the board? Yeah, Phil.
Yeah, first of all, congratulations to the whole trust on some of the recent outcomes. And I know we won't rest on our laurels because there's a certain psychological danger with being on a pedestal, and so it almost needs to spur us on, particularly at any vulnerable areas. At some point when the Health Visiting Pathfinder programme has been sort of active, it'd be really useful to see what the impact of vaccinating children at home, whether that actually makes a difference to vaccination rates, because to me that's a key public health safety issue that's not where it needs to be at the moment. And this request might sound a bit nerdy and niche, but could somebody send me the System 1 use of task policy? It's not something you normally hear from me, but actually, knowing System 1 and the use of task, it's actually a critical safety issue. And as chair of Quality Committee, I'd like to understand it. This is the system in System 1 where key clinical and administrative tasks are passed around the system, and many a general practice has got themselves in a complete mess with this. And there's always a tension between personalised care and the individual taking responsibility versus the system ensuring that all tasks are dealt with appropriately relative to their urgency, and making sure none are missed. And in practice, I've seen lots of issues. So I'd love to see how Kwame sorted this out, and it's a check as well, because I want to be assured that policy is clear and there are key governance safety mechanisms in place, because it really can go badly wrong.
Kwame's nodding, so I think that's a yes. I think now you've raised that, I'm sure all of us on the board, particularly the non-exec directors and myself, would be interested to see the outcome of that exchange of information as well, Phil. So it'd be great if you can sort of share maybe a note around afterwards about that and what you found. And I'm sure if you want to, it'll come up at Quality Committee under your chairing as well. Great, thank you for raising that. Keith.
Thank you. And to add my thanks and congratulations, I think, around the segmentation and the work around that from the team, because that is clearly an outstanding result. I had a question. I saw yesterday, I think, or the day before, that there's money being given out to organisations that have delivered on their budget versus organisations that haven't, if that makes sense. Does that include mental health? And if it does, are we likely to receive any of that? Michelle's face tells me that possibly that's not the case. But if we were, do we have an idea of what we would do with that were we to get it? It sounds like we might not, based on Michelle's face, but I just wondered whether it was mental health wasn't included in that, or whether it was all organisations. Sorry, that's a rambling question. Sorry.
Thanks, Keith. Pete.
I'll pass over to P, but I'm picking it up nationally, but I'll pick over to P.
Pete.
So all sectors are included, Keith, so no sector is excluded under the rules that are applied. There are 3 rules to be eligible for bonus funding. Rule 1, you have to be on plan or better this financial year, so we tick that box. Rule 2 is you have to have submitted a compliant plan for next year, we tick that box. Rule 3 is you have to be in a system that is delivering its financial plan, so we don't tick that box. And reaching out to local mental health trusts, many are in the same position, but any funding that is allocated, Keith, just goes onto the bottom line and becomes a surplus. So it is available for capital in the future, and it will improve the cash position, but it's not available to be spent on revenue, if that's helpful. Well,
that's
not
very
helpful,
clear.
really, let's be honest.
That's very clear. The power of 3. Keith.
Can I just say that that's
I'll
really
take
clear?
it.
Thank you, Pete. Am I allowed to register that that just makes no logical sense whatsoever at all, in the sense that you penalise organisations doing well simply because the surrounding organisations are not doing well? I think we should lodge the foolishness of that.
I don't think you have to ask. I think you have duly lodged, if that's the right verb. Michelle.
Thank you, Keith, for that support. But it has been duly lodged several times already. But I will continue to lodge it. I think that's what that's why I was a bit frustrated, because you're absolutely right, and it does tend to. And picking up Caroline's point about the budgetary finance position of mental health, it does tend to disadvantage mental health and commuting more because of the fact that the acute systems are in that deficit position. So that's why I've already raised the issue with the national team and the regional team, and I know that Pete has, and we've got a meeting later that we'll continue to do that. But we're also taking a bit of a sounding board about what the other regions are like, because then it makes the discussion that I can have with the centre stronger if we can demonstrate that it clearly does disadvantage mental health and community trust, but specifically mental health. So thank you for that, Keith. It's a really good point, and it does not make any logical sense whatsoever. And there's no incentive there, is there, if you're working in a system, especially like ours, that is so short of the mark? What is the incentive in a way for us to continue to develop, as it were? We are going to continue, obviously, because that's the makeup of us, and our patients are the most important thing that we're here for. But yeah, you're right, I don't make any logical sense. I'll be quiet. It's a frustration at the moment, but thank you, Keith.
Pete.
I think we all share the frustration, Michelle, and if people have a chance to look at the HSJ, there's an article on the HSJ in the comments. I'll reiterate the balminess, if that's the right language, of the approach that's been adopted.
Okay, balminess, that's it, lodged, all these technical terms that we are now using for this area. I mean, I think we have had a discussion about the board when obviously the centre talked about the advanced foundation trust status. And we were talking strategically about, well, what that would mean, why we'd do it. And just to echo Michelle's point, whatever the situation, we will continue to work hard to be the best we possibly can, whether it's segment one, keeping our finances sound, whatever other assessment process they throw at us and send to us. But at the same time, it does beg the question around, you know, incentives in the whole system as well, and how you actually enable people who are, you know, who are doing well, delivering well, sound foundations, sound finances, to be able to do more and have flexibilities within that. And I think, you know, that's something the centre's going to have to sort out, because it's just mixed messages, and there's a lot of work every time they send something from the centre out into the system for another sort of, if you like, a hurdle to get over, or another assessment to be done. It involves a huge amount of work, and we know that, particularly in the last 6 months, everybody's been working on to good end, but it's a lot of work and a lot of time. Okay, right. If there's no other questions or comments, I think we can conclude the Chief Exec's report. There's a lot of information there from the comms team and from health staffs as well. But before we move on, can we just go through the policy changes and ratification of these? I'll just say each one and get a sort of, if you like, ratification hands up for each one. The System 1 use of task changes. Everybody content with that? Uniform dress code and ID badge. I found that very interesting reading through all of that, I have to say. I will be now, I mean, I was interested in what haircuts you could have and all of that, actually, and interesting stuff. So my learning curve went up enormously on that. Everybody happy with the changes there? Great. Nice implementation. Happy with those. And the leave policy. I think we had a version of this before, and I think it's gone back and come back again with some changes, a few changes in it. Everybody happy with that? Brilliant. That's great. That's the conclusion then, the Chief Exec's report. Michelle, publications and highlights.
Yeah, thanks, Chair. Usual report. Again, I'll take it as read. We've got the main publications that come in that we're not doing separate papers on, or we're not picking up in other parts of the report. Got a director's little update about how we're going to deal with that in the organisation or what we've done. I'll just take it for comments or queries, Caroline. Thank you.
Thank you very much. Open to board. Kwame. Oh, no, sorry. No, I think we're okay on that. We'll move then on to the item number 9, the patient-led assessment of the care environment in 2025. Pete.
Thanks, Caroline. And Caroline, I know you sent me some queries last night, so I'll try and cover those when I present the paper, hopefully. So this paper presents the 2025 place results, and we did see these results yesterday at EMT, and overall, I think we agreed that they were quite a good, solid set of results. Whilst not in the paper, I'd like to thank all the staff, volunteers and governors who participated in the assessment process. You know, it was the first time for a while that we've had governors involved, and I think, you know, they did add value. You know, at aggregate level, I think as a trust, we've made significant progress, and it's pleasing to see that the number of exceptions or actions that come out of the assessments are significantly lower this year. So we've reduced from 382 assessments last year to 162. And progress against the 162 will continue to get picked up at the Trust Health and Safety Group, and that then gets ported into exec. I think whilst there's still work to do, we have noted the positive progress we've made both on dementia and disability from where we were possibly 3 years ago. You know, that's probably the area that's improved the most. But in terms of dementia, there are a couple of sites where scores were a little bit lower. So we are now progressing with the work at Malton. It has taken us a wee while to get landlord permission to do the works there. You know, but we are now progressing with the dementia-friendly work, and Health Stars are supporting us with some of that. You know, so that should have a positive impact on the dementia scores. And we are looking at the exceptions for Millview, but we do always take on board that Millview is a functional ward rather than an organic ward. So sometimes there is a bit of a challenge of what the place assessments are assessing. You know, and as an example of that, just for information and probably a bit boring, you know, one of the assessments on places for dementia is having dimmable lighting, if I can even say it. But that is at odds with health technical memorandum that talks about having standard levels of lighting for clinical activity and for safety. So, you know, there's a bit of a dilemma there. But for all wards, we have action plans in place now that are monitored through health and safety. We've got resource continue to be set aside in our capital programme for place and statutory compliance, and we're hopeful we'll continue to see progress on these results. I think I'll stop there, Caroline, but I'm happy to take any questions.
Thank you. Any questions from members of the board? I've got Sarah and then Phil and Kath.
Thank you. Thanks, Pete. Great paper. And I think from my perspective, I just wanted to sort of assure board that I really closely look at this report with Pete, just triangulate all the other things from a sort of patient safety and an environmental perspective. But I'm really sort of supportive of the report. It's really positive. Acknowledge there's a few bits that we need to do, but we know those actions are ongoing, but just so that board's assured on that wider triangulation. Thank you.
Thank you. Phil?
Yeah, just trying to triangulate it, what people say to us when we go on visits. And it's really great to see that we're excellent for food, cleanliness and disability access. The one thing that staff do bring up to us, it's probably almost a single thing, is the responsiveness to maintenance and when issues happen. So maybe we could just look at that, because that's happened a few times and I've been on a few visits. It's almost the one negative that you get. Everything else is incredibly positive. So overall, the visits are wonderful and affirming. But that is something that comes up fairly regularly.
Thank you, Phil. I'll come back to you at the end, Pete, if you want to on comments from colleagues. Yeah, to sum up. Yeah, Kath.
Yeah, once again, it presents a really strong picture, I think, and Pete's just talked us through some of the lower scores on dementia. So I'm just going to ask the obvious question. There was a slightly lower score, albeit in the context of it's still a good score for Millview on the ward food. So I don't know if there was any context to share on that, because obviously I'm not able to triangulate, so I've not been to any of these places yet, but I hopefully will be going over this coming year. So thanks.
Yeah.
And
so
let me just see if there's anybody else. No, and can I just add one in, Pete, maybe to explain a bit more on the dementia side of things? How much in advance of the actual assessments was it already on the radar, some of these issues? And on the dementia from Malton and Millview, one of the things I think I picked up on was the lack of, for example, a memory area, which is often something around, you know, just very prevalent in residential care homes and other places as well. That seemed to be not present there. That seemed a relatively easy thing we should have been on top of, not necessarily subject to a landlord changing the fabric of a building or something like that. So if you could pick up on Phil, Kath's and my comments, that'd be great.
Yeah, more than happy to do so. So in terms of Phil's comments, I guess what I would ask Phil is, when someone mentions timeliness on repairs, can we ask the question on the visit, has the job been logged with the estates department? Because we do see a report at the Health and Safety Group, and I'm happy to share that to the board. And I think, and I may do myself an injustice there, but from memory, about 98% of jobs that reactive maintenance jobs are completed within the required timescale when they're logged with the estates. So, and we see that dashboard at exec as part of the health and safety quarterly report into exec. So one of the things I always say, and this isn't defensive, so please don't take it that way, is that people know how to log jobs and have people logged a job. Because, if a door's jamming, and I'm going to tell this story because I've told it before. Years ago, I was at Trust HQ and somebody came to my office and said, "Oh, you're in charge of estates, aren't you?" And I said, "Yeah." She went, "That fire door there has been jamming for 6 months." And I said, "Which fire door?" And I went and down the corridor with a lady and she showed me. And I asked her if it had been logged and she said no. And fair play to her, she logged it. And then she came to my office 2 days later and said, "I just want to say that door's been sorted and they've done a really good job." So I'd implore everybody out there to log jobs when they need to be done. In terms of the food at Millview, Kath, that is on our radar. So at the moment, we don't prepare the food at Millview. It's brought in because it's part of the Castle Hill site. We are looking at options about being able to provide the food ourselves and bring it in hot boxes from possibly somewhere like the Humber Centre. So that work is in transit. It's just been delayed a little bit because we've currently got a vacancy in our catering manager. And then for the Malton, I guess, and take this in the spirit, Caroline, it is challenging to be able to do the work. It has been challenging to be able to do the work at Malton because we don't have a formal lease and we do depend on landlord permission just to paint the walls or take a picture or even move a fridge, I have to say.
Okay.
Now, we are close to getting a lease formalised, but the work we have done at Malton, I just put a couple of examples in the box of getting the doors wrapped, which, to be honest, we've been wanting to do that for 18 months, but just getting the landlord to give us that permission. But once we get that formal lease, we will be able to take in a full repairing lease, and then it becomes in our gift to address some of the things that staff often tell me when I visit Malton as well. So hopefully I've covered the three.
Thanks for that further explanation. I think it just paints the picture a bit more for us about what the obstacles might be. Thank you. Michelle.
Yeah, just to reiterate, I was going to pick up what Pete said. I think all good points. Thank you so much. And yes, I suppose from an exec team, we are a bit disappointed. The good results, absolutely, and we're always striving for that perfection. And the food, actually, we had a conversation yesterday at the exec team about that, on how we can expedite it. Malton is, I suppose, a bit more of a frustration, and we do appear to have a few today, don't we? But in as much as we cannot do anything at Malton without and literally moving a fridge, and that we have that conversation, which is why we're really pressing for this lease ownership. So we'll continue to do that, and I'll continue to work as much as I can with Pete and the executive team on that, so that, because that'll make it a lot better for us to do, because it's just been so difficult to do. But just to reiterate, I do want to thank the governors particularly. I know we were mentioned earlier on. I think the governors, it's really important they're involved with these visits. I mean, I'm not saying that other staff aren't important that are there, but I just think giving that slight independent type viewpoint is really helpful. So if there's any governors listening, or for the minutes, please, if we just strengthen that about, I know Pete mentioned it, but just to say thank you sincerely for the governors, because I know it is hard work doing the visits. But also to reiterate, please make sure that staff do log things, because they have got a habit of just saying that they've been waiting and they haven't, because they do need logging. So again, if we can just remember that on visits, that would be really helpful. Thanks, Chair.
Thanks, Michelle. And again, governors were really, the governors who took part, it was they all fed back how much they found it really worthwhile from a governor perspective too. And I think one governor in particular did a huge number of the visits, so he did a great job. Brilliant. Okay, I can't see anybody hands up there, so thank you for that, Pete. Good stuff. Moving on then to item number 10, Sarah, executive briefing, Town and Court.
Thank you, Chair. So you've got a brief summary of the CQC inspection report. CQC inspected Town End Court on the 11th and 12th of November last year, received the report, and we did a number of factual accuracies. What you can see from the report is that overall we achieved a good rating, good across the domains other than responsive, which was in relationship to requires improvement. There's some real positives noted within the report around sort of culture, compassion, dignity and respect, sort of leadership and improvement culture, which is really, really positive to hear. There is a number of improvements that are detailed within the report, which obviously we are working on from an action planning perspective, and that's just around sort of care planning, environmental, length of stay. And it's really interesting because some of the things that some of the colleagues have brought up, so the length of stay stuff, Kath, which you alluded to earlier, we know that the length of stay for these particular patients are very much bespoke onward transfers of care that, you know, really do need to be developed, and that. So this is where we do have some real sort of challenges around some of these bespoke placements, which unfortunately are out width of our control. But it is something which is continually escalated through our MAID meetings, as Lynn's alluded to, but also our system, you know, meetings as well. And I wanted to sort of again triangulate with what the conversation that's just had around sort of maintenance as well. So some of the evidence that we resubmitted with the maintenance, I saw the detailed estates log specifically for Townend, and I was absolutely shocked the number of entries within just a month's period. And I think the challenge that we've got is because of the nature of our patients, you know, damage is caused quite frequently to some of our units, and that the things are being logged, but it's about, you know, the timely repair, which you can see, but sometimes some of the more of the really sort of hard wearing things that we have take specialist orders and things like that. So that was some of the narrative that we sort of shared with sort of CQC as well, is around as soon as you fix something, half an hour later that could have there could have been an incident where you see sort of further damage. So overall a positive report, but again, as Michelle's alluded to, we never sit on our laurels, so there's still more to do, and we'll do the action planning, and we'll monitor that, and obviously CQC will have oversight of that improvement plan as well. But happy to take any questions.
Any questions? Okay. In terms of report, oh, Phil, sorry. Yeah, Phil.
Yeah, I think Sarah sort of answered most of my questions, but one that obviously we're trying to get sort of improved and high quality in the whole trust is communication with families. So how are we reflecting on that? And you know, is it a cultural change that needs or to happen, or is there some systems that can make that better?
I think, and again, this is where I don't, there's always areas for improvement. What we've got to be really mindful of is that in relationship to the Townend inspection, because of how small the environment is and how there's very few patients on there, what I'm mindful of is the cohort of people that CQC spoke to was a small cohort of people. So what you could question is how reflective is that overall of the services that we provided. So one of the comments that is featured is that communication wasn't consistent. So, you know, we have to, at the end of the day, we didn't get it 100% right. So we have to acknowledge that, and we have to do sort of more work. So it's around acknowledging that there's still to do, but sometimes in these smaller units, because of who CQC speak to, it's not necessarily totally representative. And I'm trying to say that in a non-defensive way. We still need to do more, but I'm just kind of trying to provide the context.
I think there was something though, wasn't there, about, and this goes back to an earlier discussion, that some of the care plans weren't written in a way that was particularly in the language that's accessible to families and patients. So I think there's a wider issue there, isn't it, which is linked back to the earlier discussion about, you know, what good practice do we provide, what sort of, if you like, you know, samples of what a good care plan looks like and how it's written, and is something we can, you know, it's not just about Town End Court. We need to, we need to work on it. We need to work on it, yeah.
And we've identified that as a trust, and it is one of our big improvement and audit areas as well. And it, you know, it is part of everything that we're trying to do in relationship to that, making sure it's written in a way that the patient, the service user, the family understand, not written as a professional. So yeah, definitely.
Okay. And in terms of, just so probably it might come back to Phil, I suppose, in terms of sort of update on, you know, the areas you've identified, the 4 areas for focus, will you be coming back through, obviously you'll have your operational groups, but will there be something going back to quality committee on that and an update on actual progress or solutions? Like, is there anything we can do about, you know, what supply of particular fixtures in fittings, if you like, we can maybe see if there's any improvements there can be made on to in that space? Will that be coming back to quality committee?
It'll automatically, so the first draft of it is already in the insight report that's going to quality committee already. Right. And then the routine updates will already be part of that. So that'll be that ongoing monitoring.
Okay. All right. So Phil and other colleagues on that committee, you'll get another look at what the outcomes of that were going forward. Great. I can't see anybody else's hands up. So thank you for that, Sarah. I suggest we have a break now till 11:10 and then come back for the electronic patient record item number 11. Thank you, everybody. Welcome back to our Humber board meeting, and we are at item number 11, and Lynn will be leading on this. It's our electronic patient record optimisation update. Lynn.
Thank you, Caroline. Yes, so obviously we have now completed the implementation of the new electronic patient record system 1. Through that period of time, I brought very regular reports to the board, but just wanted to give you an update in relation to where we are now. So we have moved the remit of the implementation, the EPR programme board, to the System 1 optimisation group, because obviously what we have, as you can see in the paper, we had through the full business case that we developed, expected benefits realisations that we would achieve through this programme of work. So hopefully you can see that we are tracking those still. So we'll continue to sort of bring updates in relation to those. But importantly, obviously, implementing the system is one thing, optimising it, demonstrating that we want to make sure that from a staff and patient point of view, we're using the system to its best ability to support our staff and patients as well as it possibly can do. So we continue to do that through the optimisation group. So I continue to chair that group, obviously very much supported by the digital team in that work. We continue to have very good clinical engagement and operational engagement in the work as well. Clinical engagement is obviously really key. So what the paper describes is a number of approaches that we're taking through that optimisation to complete the work. So clinical engagement happens through a variety of different mechanisms. Latterly, each of the divisions have completed a piece of work to prioritise where they would want to see specific improvements in the use of System 1 across their services. That sort of piece of work has now been prioritised itself. And in effect, that forms the work plan now for the optimisation group going forward. So you might have seen some of the trust communications lately. So for example, there has been a new template developed to collate all of the safeguarding information in relation to individual patients. Again, that was a request by the safeguarding team, but also absolutely sort of needed and wanted by the clinicians as well, to make the recording of that information really clear, really accurate, easy to access in the new system. Similarly, there's been some work done around medication optimization as well, with some new templates introduced to System 1 in relation to that too. So there's a variety of different priorities that we've agreed through the programme group, and we'll continue to monitor and engage and update. I'm sure it will be a sort of process that will be iterative as well. We'll continue to work on ensuring that we prioritise and optimise where we're able to. The report also describes that whilst we completed training, and that was one of the key criteria before we pressed the go live button on any of the phases of implementation, now what we're doing obviously is training new staff as a business as usual regular basis, but also doing some bespoke training where people and staff have identified that they need some specific training in a specific area of System 1. So that's being applied as well. There is a connection to the productivity and efficiency work that we do as well. So there is some information in the paper around that, but obviously that is part of our wider work on productivity efficiency. But we do want to make sure that this system is optimised again in terms of its usability. So things like the fewer number of clicks to get to a particular part of the patient record. Obviously, it's a simple explanation of that, but obviously really important from how much time it takes staff away from direct patient care to complete the records. We want good quality records, which we've discussed already this morning, but we want those to be achieved in the most efficient way from a clinical staff perspective. So there is a connection to that productivity and efficiency work. Overall as well, there has been some digital innovations and changes at the same while that the EPR system has been implemented. So, and obviously there is a connection between those new digital tools as well. So for example, the lexicon, the voice recognition software, obviously the sort of Bridget mobile app, etc. So those are the appendix of the paper. But collectively, those sort of bring those efficiencies, productivity, benefit to our staff and benefit to our patients together as well. So there is work taking place to sort of measure the impact of those, where they reduce time of staff on the system, but obviously where there's some cost implications. So for example, obviously not having to send physical letters because of the apps that have been applied to the system too. So our intention is this group reports through to the digital programme board, through to EMT as well. And whilst the implementation was a sort of task to finish group with sort of a time frame to it, I think our intention is at the moment we would just continue this work continuously as part of our improvement work overall to maximise that benefit of the new EPR system. So hopefully that gives an overview, but I'm really happy to pick up any questions.
Okay. Any questions from board? Kwame, and then Phil, and then Kath.
Just a contribution to say that the working relationship between the clinicians and the IT team in the implementation has been really, really good. And I was using our clinical advisory group with working together, operational team has really been good. I also wanted to emphasize on the cost effectiveness on some of these programs. I look at something like EPS, and although if it might save clinical time, it is such a safe, effective process which helps patients, and it needs to be taken into that context. That is one of the things I wanted to highlight, that all these developments is not just about cost saving, but it's cost effectiveness, and it is safe for patient and it's safe for patient care. Thank you.
Thank you, Kwame. Phil, then Kath.
Yeah, it was great to hear from Kwame that the clinical staff are working well with the IT staff, because this is not just a digital opportunity. This is an opportunity to redesign how we actually work, and fundamentally a good digital system will change clinically how we practice. We talked about tasks earlier on. I was just seeking a bit of assurance that we've got ourselves fully sorted with the acute trust pathology ordering system, because I'm thinking about the benefits for clinicians, and when that works well, that really enhances patient care and makes clinicians' lives easier. And some assurance that we've got full adoption of electronic prescribing, because in primary care we didn't fully realise the myriad of benefits that full electronic prescribing brings, from being able to audit, from quality, being able to adopt and follow formularies, lots of benefits that you didn't fully think through. But I just wondered if those areas are being fully adopted.
Kwame, do you want to pick up those? And obviously, Phil, it's not just electronic prescribing, is it? It's the electronic administration of medications. And obviously that's been part of our rollout as well, making that sort of transparent and even safer than old systems. But I'll let Kwame comment.
Could you just add to that, in answer to that? Anyone involved in that? Where are we on the training of everybody and actually using electronic prescribing?
So in terms of the electronic prescribing, it was launched last year, and we have done a series of training. We have how to use it on the line. We added to EPR everybody who is a prescriber, both medical and non-medical prescribers, training.
Have they all had it?
This is one of the things that we have set a deadline of the 1st of April for everybody to have it, and we're going to check on that. The other thing that we're doing is to make sure that we achieve at least 95% of prescribing using electronic prescribing, because of all the benefits, and we set ourselves and did that ambitious target. The very small one is for controlled drugs and the blue FP10s, but that is where we are going. It's clearly trying to get doctors away from their prescribing pad, has been a bit of a challenge, but we are using the support. Myself and Matt were training the doctors last week, just before I went on leave on the 4th of in March. So it's a case of getting everybody trained and ready to make sure that on the 4th we are fully, on the 1st of April, we are fully using electronic prescribing.
Is that
Good.
okay, Phil?
Yeah, no,
Okay.
it's just that the benefits are just so powerful
It is.
that
It is.
it's not an optional thing. It should be mandated because that's the learning from general practice, and the flexibility for the patient and the safety from a system and clinical is just overwhelming.
Yeah. I
Agree
mean, I
with you.
agree. It seems like a bit of a no-brainer that we've got the system. It should be mandatory. I don't know whether that should be added into the sort of that's for you operational people to sort out, whether for certain clinicians there's certain aspects of training that should be mandatory over and above some of the other staff in the organisation. Might be worth a look at. Kath.
Yeah, thanks for the report, Lynn. Really good to see all the data in there, you know, financial and non-financial, particularly like the, you know, information around preventing did not attend, you know, that kind of patient impact coming through as well. So the one question I was going to ask is kind of on the staff engagement, and I guess, you know, so staff on the EPR had the training, etc. As part of your optimization, are we able to ongoingly understand that people are utilising it and that they're logging on and using it as their main form of, you know, recording patient contacts?
Yes, absolutely, Catherine. And we introduced that right before each of the go lives as well. So if anybody entered anything into the old page, they can't actually do it now because it's closed down, but we monitored that very closely as well. So we do have a patient safety officer as well dedicated to this work. So that's something that he brings reports to the EPR optimization group in relation to. So I'm very satisfied that we have got that position where we know that everything should be recorded in the electronic patient record. There isn't an alternative now. Actually, we did double run the two systems for the sort of archive for a while, but we've now got to the position where they are not able to write into the old systems, but it is continued to be monitored.
That's great. And I was just going to ask about the optimization. How long do you think? And I think you started to answer that at the minute. You still think there's lots of merit in carrying on the optimization program. So you haven't got a plan for, we're going to do it for 18 months or 2 years or whatever.
I guess we'll continue to obviously, Kath, where we can, we want to. That's why we've got the prioritised work plan as well. We will get through that prioritised plan, and obviously we have put timescales into our sort of plan around that. But you know, at the moment we're still getting requests coming forward as well, and we don't want to close down those requests. But we will absolutely, you know, review at least, you know, every 6-12 months. And report to ENT as well where we are in this process. So as I say, it is in the governance structure around sort of the digital programs overall. But what we didn't want to do is say it's a task and finish group right now, because we really want to make sure that our staff understand we are committed to optimizing this system. And actually, as it stands, we're not going to sort of draw a line on that right now. I think we'll have, you know, because of our wider improvement work, the electronic patient record is always going to be central to that, isn't it? So we need to be mindful. But I think obviously we will get through to sort of the general request at the moment, but as soon as we get to that point, there may be more specific sort of work that we commit to in the future, and we won't see the sort of volume that we're doing now. That will reduce.
Yeah, that's helpful. Thanks, Lynn.
Thank you, Kath. Steph?
Thanks, Lynn. Yeah, certainly speaking to staff, the system has been very, very well received, and people are very, very enthusiastic. And of course, as you get used to using a system, you see opportunities, don't you, for improving the service that we provide, making it more efficient, getting more information out of it. So it's not surprising that we're continuing to get requests coming into the group, which is brilliant to see. Just a question then about resources, because for example, in the BI team, so for example, I've seen on wards and in various services, things like whiteboards being developed, case management. systems being developed, which are brilliant because they're sort of real time now. They're electronic, they can be shared. It's really good development, actually. But have we got the resources that we need within our BI team and elsewhere, for example, to get these improvements moving as quickly as we would like?
I guess maybe Pete will come in on that as well, but certainly in terms of what we've committed to, Steph, and that visualization of the electronic patient record, we absolutely are committed to as well. And we are committed, obviously, that, you know, I think that's why it's important we don't put a deadline as such, because we continue to improve our services and our patient pathways all of the time, don't we? So actually having the electronic patient record as part of that transformation change is going to continue into the future. However, you know, it's not an infinite resource that we've got. So that's why we do that piece around prioritization as well. So where we, you know, agree, and those prioritizations are agreed clinically as well. So that in terms of that's the patient safety piece we've already touched on. So the reason why we're doing that is that we understand the resource that we've got available and we're matching that to the work that we're doing. So there is that sort of expectation that we can't do everything at once, but we are doing those prioritised things. So that's how we're managing the capacity at the moment. I don't think there's any issues with that. I think the prioritising work has really helped us with that. But Pete might want to comment separately. Pete?
Yeah, thank you. I mean, I would have said pretty much the same as you, Lynn. I think BI is often an area that's under pressure. You know, we talk about prioritisation. That's a conversation we often have at exec, but you know, quite often it's the things that come in left field. So we're going to have a new oversight framework. We've got the culture of care programme, health inequalities, PROMs, CROMs, and everything else. So it's a conversation we have continually as an exec, isn't it, about how we prioritise the work of the BI team. So we are cited on it.
Okay, thank you very much. My just sort of observation on the appendices A, B, C is just how much maybe for future reports correlate together. I know we're in early days of some of this, but I just thought, you know, we've got this sort of full business case with lots of very, you know, distinct columns in it. I'm just wondering how we're going to sort of triangulate the results as we go through to come. So down the road, whoever's here on the board at that time can look at that and say, did we realise our ambition? And just seeing how that might pull together more. And the other thing, just to say, obviously we didn't go live in May 2024. We did it and we decided to go in 2 tranches. I think again, you know, it's perfectly reasonable then to reflect in the benefits planned, to reflect that, I think, positive decision that was made at the time and how that fits in. Do you see what I mean? I think it's just sort of that's yeah, I just felt in terms of, I think it was Appendix C, that as far as I can see, yeah, benefits plan to begin from financial year 26-27. And I know we'll do that, but we might not be as far ahead as we might have thought we might be. And I think it's that optimism bias, trying to avoid that coming in and being reflected, if you see what I mean, Lynn. Is that, have I?
Yeah, I thought that we'd explained it, that the benefits realisation will be put back a little bit, in line with that sort of changed phasing that we did, which was the right thing to do, as you quite rightly say, you know, for patient safety reasons at the time. And I think that contributed to the success of the implementation, but that's a very good point. There are more detailed reports, Caroline, through the Be Digital governance on the benefits realisation as well. That's sort of a paper specifically about more detail about where we're up to with those, and that will continue as the programme goes forward.
And of course, we've got an internal audit sort of thing going on at the moment about digital governance, with colleagues have all taken part in as well. So that will play into that too. Thank you very much. Okay, thank you. We'll move on then to the National Staff Survey results. Alison, you are very welcome to stay, but we're running a bit behind. So if you wanted to come back in 20 minutes or so, half an hour, I'm sure that'll be fine. And if someone can let Oliver know that we're running behind as well, so he might want to add 20 minutes onto his time ahead in terms of coming back. Great. Karen.
Thank you. So yes, I'm really pleased to be able to present the 2025 National Staff Survey results. And I know that we have received a report into the private board previously when the results remained under embargo. but the embargo was lifted on the 12th of March, and at that point the national results were published, and that's a really important point for us in time for us, because it means that we can start to really look at our comparative position, whereas previously, because the results filter out over a period of time, what we spend our time doing is looking at and comparing our own local trust position compared to the year before. So in terms of the high level position, and communications have gone out to the wider trust as well. Michelle did send out a communication to everybody on the day that the results were published. So really pleased that we had the highest ever response rate, giving us a very robust and representative picture of what our staff think about working at Humber, not just as a place to work, but also a place that provides care. It's really pleasing to see that we continue to outperform national averages across all 7 people promise themes and the 2 overarching themes of engagement and morale, which is really important for us, because it goes to show that the work that we're doing really is paying off, and we can then look across at our peers and our partners and know that the work we're doing is certainly making a difference. What's really important for us is that the advocacy sub-theme, so it's a sub-theme as one of the people promise themes, remains really strong. So 70% of colleagues at our trust would recommend us as a place to work, and that actually places us 7th out of 49 providers when compared to our benchmark group. And I think what's important to pull out there is that's a sustained year-on-year improvement. And when we look at, and there's an appendix that shows the rankings of mental health and community providers towards the end of the report, I think what's fairly telling is that within that top grouping, that whilst there are some that outperform us, what you're seeing is that their scores are actually slipping back over that period of time. So their baseline position was stronger and they've fallen back, but they've maintained a higher position. What we're showing is, what we're always really proud of, is that sustained incremental year-on-year improvement. And like I say, that the advocacy question is very important to us, because again, it gives us that confidence that staff genuinely value the things that we do to make Humber an employer of choice. So some of the key strengths, we continue to move ahead with compassionate culture and inclusion, and again, that's really important. We've talked earlier this morning about sexual safety, and we referenced Being Humber and the Respect campaign. We know that we've delivered a lot of work in the sphere of kind of ensuring we've got a safe environment to report incidents, and opening up our trust as a place where people can share their voice and their views, and that comes out really, really strongly, and again, something to be really proud of. Team working comes out really strongly, as does flexible working. Again, we know that we've kept the momentum around agile working here. What we can see is that 88% of staff say confirm within the survey that their role makes a difference to patients, and 82% say that patient care is the organisation's top priority. Again, something we're hugely, hugely proud of, because that's why we're all here at the end of the day. In terms of equality, diversity and inclusion, as I've touched upon, we are above the national comparators, and also showing that improvement again in that sphere of bullying and harassment and discrimination. Again, whilst they're separate questions to the sexual safety question, we're showing improvement across, which goes to show that we've got some real strength and alignment across that programme of work broadly. And I think the other thing to mention, I know we've talked about the National Oversight Framework previously this morning, but actually there are 2 areas from the staff survey that where performance is within the oversight framework: engagement and raising concerns. And again, we're really proud to have moved from 20th to 10th for our engagement score. And also we've remained on raising concerns, we've remained 13th, and they're both out of 61 trusts. So what I will say is that oddly, those results haven't been captured within the Q3 National Oversight Framework position. If they had have been, actually we would have seen a further shift in improvement within that score. So I think that's notable. I think what's really important is that we always, and I think Michelle's referenced it earlier this morning as well, it's really important that we sit up and take notice of the areas of focus for our trust, because again, it's one of the primary reasons that we've improved in so many areas, because we take that feedback incredibly seriously. So the key areas that have come through for us, and I think it's worth noting that whilst we are faring very well comparatively, for us it's always a little bit of a concern when we compare ourselves to our performance previously and we've fallen behind. So there is a national trend that people are talking about where scores have dropped back. We have dropped back marginally in a number of questions, and that's not a position that we like to report. And so we're really taking note of that and moving forward with some specific actions. But the key areas that are coming out for us as key areas of focus are appraisal quality. And again, we've really worked on compliance with appraisals over the last few years, and we stepped up last year around those quality conversations and how we can equip managers to deliver them. That still needs some work according to what staff are telling us in the staff survey. There are some health and wellbeing indicators, again, that we've seen come out in previous years, and we need to build on the work that we're already doing. So particularly MSK was a bit of a surprise to us, but again, there is a national trend around people reporting musculoskeletal issues within the workplace. So that's something we're really focusing on. We do have a lot of resource and support within the organisation for that, but we are going to elevate that over the next few months. And then what's persisting is some concerns coming out of the survey around burnout and psychological support. So again, from an EMT perspective, those 3 areas have come out as areas that we want to pursue across the organisation as those broad priorities. And I think the other thing that we've really noticed within the survey is that staff are saying that they're not maybe as happy in their day-to-day work as they were previously. So feeling valued and understanding more about that from our staff is really, really important to us. So in terms of the work underway, they're the 4 themes that have come out that we're going to focus on organisationally. Locally at divisional and directorate level, there'll be work to look at what their own surveys say for them. So there will be local action plans that will report through the accountability reviews. But also what we've already stepped up in only a couple of weeks post the sort of publication of the surveys, a listening exercise to understand people's views on how they feel valued at work, whether they do, whether they don't, what we could do differently, how we could invest differently in health and wellbeing, etc., etc. So that's ongoing at the moment, and we expected that to carry on through until the end of April. So I think I would just end with, I think there are really strong set of results when we look at the national context. I think it's fair to say that we've got some work to do, and we're really clear on that, on what we want to do around that, and we can report further updates, particularly through sort of EMT, the people committee, and then back into the board in terms of the difference that that's making. So I'll end there, Caroline, and take any questions.
Thanks very much, Karen. Any questions from anybody? Kath.
Hi, yes, thank you. Echo the strong set of results. You know, it's a report that makes such a good read and lots of positives in there. So really well done. And obviously, as a newbie, to have this piece of information and assurance right at the start of being a non-executive, it's really valuable. So I've just got sort of two questions really. One was around right at the end of the report, you're talking about the kind of the key themes from a trust-wide perspective, and then you talk about the local priorities, because I guess we recognise there might be different priorities in services and teams, and that's great to recognise that kind of local action. They should have the empowerment to be able to make changes on local level. So I just wondered, A, how are they kind of supported to do that, and B, are there any teams or services who are, because this is an aggregate position that we get at board, are there any teams or services that are any kind of concern for the trust, as in needing additional over and above the usual support in order to help with their results?
Yeah, no, that's a really good question. So the first thing is in terms of that cascade, so the report that we've got at board, there are similar reports that go to each division, and they also get, alongside that, their raw results. So they will sit and spend time within their leadership teams, with their HR business partner, and anybody else that they want to get involved in terms of understanding and analysing that a bit further. And then they will deliver on their own, and they all have variation in terms of how they like to do things and what makes sense to their divisions. So they will then cascade that and start to work through how they can jointly and collaboratively work up what are the right tangible actions. And like I say, from an accountability review perspective, we will then see what those actions specifically are, and then the divisions will report their progress in terms of how that's playing out for them. And as you rightly say, you know, we are seeing some parallels between what the main organisational results are saying compared to the divisions, but actually they have some nuanced areas that are maybe different. So it's important that we allow that to happen. In terms of maybe some of the more challenged areas, so we've reported this already into the EMT and ODG timeout that we have. So all of our senior operational leaders have had sight of the main reports as well as their own. And I think what we identified is mental health unplanned forensics and community services were maybe slightly off kilter in terms of comparatively compared to the trust results than we would expect. And I think they've really taken up the gauntlet in terms of looking at that, taking ownership and accountability for it, and working really robustly within their teams to address that. And we've had prior experience and confidence in divisions doing that in previous years. So again, we'll see that play out through the accountability review process in the coming months.
That's good to know. Thank you.
Thank you, Kath. Michelle?
Yeah, thanks, Karen. Good presentation. And just supposed to reassure the board. I mean, the reason why we're doing the listening exercise, it might seem a bit strange when we've just got the results of the staff survey. We've built that round about being valued, because I think there's a thread if you read the documentation about that value. And I think a lot of it links into the team leadership type. This is no criticism about team leaders, by the way, but it links into that type of area. So we just want to explore that a little bit more. So that's why we're doing some listening exercises. Obviously the general managers are, the team leaders are. This is a trust wide. I'm going to do a couple of specific listening events as well. And then we're going to correlate all that in relationship to what that gives us. And it's given us some quite rich data already that we can add to the staff survey piece. So we can really make those action plans really detailed, but also really tailored to different areas as well, and also different staff groups, because I think there's not only the differences in the staff group, which is a really great question, Kath, but there's also differences within professional groups as well that we need to understand, and the pressures on there. So I think hopefully that will just round it off. I'm doing that quite quickly, so we don't want to, because obviously the problem with the staff survey is by the time you get the results and you've analysed them, the next staff survey is out. So you're almost like chasing your tail a little bit, but they are positive, but we're not sitting back on our laurels. As people around the table know, it's something I feel quite passionate about is staff and staff engagement and that cultural piece and that inclusivity bit. It's not just because I'm passionate about it; it's so important to the organisation. But yes, we're still on the right track. Took a bit of a bump in the road this year, you would argue, but not when you compare it to others. But we'll keep going. But anything that the board can help in relationship to contribute, then please let us know. You've got a lot of skills and a lot of experience around the table, so please feel free to put those in as well. But I hope that's helpful. Thanks, Karen. Great presentation. Thanks, Chair.
Thanks very much, Michelle. I can't see anybody else's hands up. I know we'll come back to this again because we'll have an independent presentation at some point, won't we, into the board as well. I mean, I do find actually that every trust is chasing their tail every year on this. And I sometimes wonder whether every year is actually the best way to, in a quality way, really be able to do something about the results and really see stuff and changes happening in the way we might want to. But that's just my opinion, but there we go. Okay, thank you. There's a lot of positives, but there's some learning as well there, and I think I've already seen actually in the comms that is going out the focus being reflected, so that's really good to see that that's up and running and live. And we'll come back to this. Great, thank you very much, Karen. We will move on then to the board. You're on again, Karen, board member appraisal process. Now we want to get our satisfaction levels up.
Certainly. Thank you. So in the board pack, you will see a quick summary of the arrangements for feedback in terms of the board appraisals this year. And I think what I would start by saying is that the board are no different to every other employee in the trust, in that for many years we have routine appraisals every year. About 2 years ago, following the CARC review, there was the publication of the Leadership Competency Framework, which added an extra layer bureaucracy maybe in terms of board level appraisals that sought to seek out that assurance that boards were fit and proper, and to align our competence to the standards within the leadership competency framework, of which there are 6 domains. So we did set about doing that, and people will recall that we had various Word documents and Likert scales and answering of various questions. So that does remain this year, and in previous years, and it was mooted last year, that the wider board would also have to conduct a 360 or a multi-source feedback exercise as well. And I know that Caroline, as the chair, has been subject to that multi-source feedback for a couple of years already. That now applies to the wider board too. I appreciate that people are busy, and filling in multiple forms and things like that can, you know, be very time consuming. So what we've done this year is looked at a way to streamline that so that it's as accessible as possible, that aligns to our digital agenda, that meets the requirements that are absolutely necessary in terms of satisfying that competency framework. So there's a couple of key changes that I wanted to highlight for the board today. So the self-assessment that we all completed last year, which was a Word document, will continue this year, but we are moving it to MS Forms. I have tested it myself. It is fairly straightforward and can be as quick and simple and straightforward to complete, or, you know, as comprehensive as you would expect. So we're moving that to MS Forms, so hopefully, and that will come out. And what we have done is done a bit of a timetable of when people's appraisals are, and therefore when do we need to circulate the various links for all of this to allow enough time for that detail to come back so that we can prepare appropriately. On top of that, now that we're introducing the multi-source feedback for all board members, we are moving that to MS Forms too. And by the end of this week, I hope to circulate to all board members the proposed stakeholders for them to respond with who those people are in relation to them. And I know that Caroline and I are going to have a separate conversation just to fine tune some of this stuff as well. But again, that all those plans and preparations are in place. And I think it's important to note that where people maybe have a challenge accessing the MS form, particularly those external to the organisation, potentially our governors, etc., we can provide a form if that's appropriate to them, and people request that. So we're more than happy to accommodate that from an accessibility perspective. There's also the normal requirement to complete our trust appraisal form, and that covers our own kind of alignment to behaviours, development, objectives, etc., and we approved that a few weeks ago in EMT, and we've had sight of the formally designed form that we're happy with. So that will be circulated in due course. So that's it in a nutshell. Like I say, Caroline and I are going to have a separate conversation, as we have done in EMT, about how we actually just move all of that ahead. Happy for any feedback, any comments, and then once we've collated that, we will get cracking with the arrangements.
Okay, I know we've got a meeting coming up. I sort of would have liked maybe that information after the EMT had cleared it, to give me enough time to have a look at that as well. But no doubt I'll be seeing, because I think there are some real issues here around the feedback side of things. My experience, to be honest, on this in terms of external, you know, it's not that great, because basically it's been every sort of chair in every trust sending around stuff about what do you know about this person, and it's just a bit ridiculous sometimes, quite honestly. But I'm interested in who we are actually going. Also on the governors, I've actually done the form for the last few years and made it actually something that is accessible for them to respond to. So I'm interested to see what the questions are that we're asking on this. So I think we're hopefully, and actually, Steph, while we're on, obviously you'll be doing, as a SID, my appraisal this year with Marilyn from the governors. We're trying to set up a meeting for, I think, next on the 31st. If you're able to make that as well, you might find it useful to go through some of these things as well, because obviously you're involved with the chief exec's appraisal too. So that's a new thing for you as a new SID. But yeah. So can you send me over what the EMT have agreed, if that's all right, today? You said you discussed it and cleared some stuff, so I'd really like to see that.
Yeah, it's all in the paper, Caroline, but I'll circulate the fine detail. We approved it yesterday.
Okay. Oh, sorry, I thought you said some weeks back.
Oh, it was the main appraisal form we approved a few weeks
Okay,
ago, not
okay.
the board appraisals.
Okay, and the multi-source document?
I can send you a link to that.
Yeah,
so
I
you'll
would
be able
really
look
like
at
to
it.
see the actual
Yeah.
documents. That's what I'm talking about. I've read the paper. I'd like to see the actual documents that are going to be shared around and being used. Thank you. Any other questions on this? Okay. I think we're looking to schedule the non-executive directors for June. So I've actually put a timetable up to Karen and others on when we get things out, to give you all enough time to fill things in, and to be honest, enough time for those of us involved in the appraisals to read through stuff and reflect on it and support you when we come to the actual appraisal date itself. Okay, no other questions. Fine, let's move on then. I'll be happy to approve this process. Yeah, okay. Moving on then to item number 14, we have Alison with us today, and Michelle and Alison are going to lead on this.
Morning, I will, just conscious of time, Chair, I'll just pass straight over to Alison. Welcome, Alison. Thank you so much for writing the report and being here. Our usual update. Thanks, Chair. Over to you, Alison.
Thank you. Morning, everybody. Just to take you through the regular report on behalf of the Mental Health and Learning Disability Collaborative, the briefings on the front sheet. There's been a significant amount of work that's been undertaken to develop the Oliver McGowan training, with specific reference to how many experts by experience that we've now got trained. So we will be continuing to increase the numbers of those and increase the numbers of those having the training. The Crisis Text 111 service, this is a nationally mandated requirement, and we have now recommenced the procurement of this, which is being led through Humber's procurement team. So we're hoping that we will have an outcome from that within the next couple of weeks. We've made a number of capital submissions as part of the Return to Constitutional Standards, the capital planning submission processes through the regional and national teams. We have been back and forth really with the regional team on a number of queries, and we're hoping that there'll be national confirmation of those capital bids by the end of the month. The focus from a Humber perspective has been on the two mental health neighbourhood hubs and also the mental health emergency department team. So we're hoping to hear back from that at the end of March. There will be a requirement for business cases and the usual governance processes that we would expect to go through to take place after them. We're also exploring the Limbic, which is an AI tool for digital as part of the Talking Therapies front door access. So working with our partners and the Humber digital team to look at the potential of this and how we might be able to roll it out across our services. We'll be able to bring an update on that as that gets developed further. And then the paper outlines our performance position across Humber and North Yorkshire for Q3. We are continuing to focus. There's an awful lot of work going on in relation to reducing out of areas, particularly from an older adults and a rehab perspective. And the individual placement support, the IPS, that funding has now been released. So we would expect to see an increase in the activity and the reporting position. I've just taken you through the headlines there, Caroline. Happy to take any questions or comments.
Thanks very much. Any questions, Steph?
Thanks, and thanks, Alison, for the really good report here. It's an amazing variety of work going on with the collaborative. Because just obviously this is a work stream of the Humber and North Yorkshire Health and Care Partnership. So it's much broader than our specialised collaborative, obviously. But could you just remind us who the partners are in this collaborative? Is it just the four mental health providers that work in the patch, or is it wider than that?
It's well, in terms of this collaborative, it is hosted by Humber. So the majority of staff that work in it are employed by Humber and is led by Humber. But the providers are Navigo, CHCP, Care Plus Group on the North East Lincolnshire side, Tees Escombe Wear Valley and Humber. And I think I've included everybody there. Have I missed anybody? And Ardash. Rotherham and
Ah,
Doncaster and South Humber. But obviously we work really closely with the other providers, the voluntary sector and the local authority, given that the majority of our initiatives and programmes span that whole system approach.
Thanks, Alison. That's really helpful to know. Thank you.
Thank you.
Thanks, Steph. So if it goes to a wider regional basis, what are the pros and cons of that for us?
So shall I come in there? That's not,
Yeah.
That's a specialist specialist
Oh,
that
that's a
will
specialist
come on
one.
later. This is the
Okay.
local provider collaborative. We are
Okay.
changing this into being more of a provider, so it won't link into the ICB as much. At the moment, it's a subset of the ICB.
Yeah.
But we're moving into that functionality to make it just provider driven. So the partners will be the same and we'll lead it, but on behalf of the whole providers rather than the ICB. Specialist Commission is slightly different and we'll touch on that in part 2.
Okay, fair enough.
It is confusing, Caroline. It is
No,
confusing.
I know, it's just because it's a bit, so Steph's point, you know, collaborative is used against these things and it's hard to sometimes work out which is what. Maybe maybe there's just, that should be fed back in for any new.
Well, we are
new
changing the
titles
name of the collaborative into the partnership from April for that very reason.
Fantastic.
One, because it's a partnership, and secondly, because you're right, everybody uses partner club and we all get confused.
Brilliant, excellent result. Phil.
Yeah, really interesting stuff, Alison. Thank you. I'm really anxious that as a healthcare system, we respond to the changing prevalence of mental health issues in children. I'm just a little anxious that the mental health support for schools is not making as much progress as I would like. I think a lot of people would like. And the other thing, if you just comment on is the sort of struggle with out of area still with only 69% achievement.
Okay, I'll pick them up and then Lynn might want to come in with a Humber sort of perspective on that. In terms of the mental health support teams, we have got a plan for full coverage by 2030, which is a nationally mandated requirement. We have seen an increase in access to children and young people's and the activity associated with that. And we're also looking, there's been new teams rolled out from a mental health support team in East Riding at the moment as we speak. And we're also looking at how we might have some flexibility to the nationally mandated model that will allow us to see more young people and somehow move away from that, as I say, that nationally mandated model. So I think there's quite a lot of work happening in this arena, and I know that Humber are looking at rolling out another team in the East Riding. Lynn, is there anything else you want to add to that?
Yeah, just on the out of area piece, it's been helpful, hasn't it, Alison, to work collaboratively. But from a Humber perspective, Phil, obviously we've now, since the beginning of the year, seen no working age adults placed out of area. So I think that's really positive, given we did have quite a number last year. So the two groups of patients that we're now focused on is PICU, which we have a plan for. And that plan should sort of come on stream by the end of Q3 this year at the latest. And that plan is assuming that we will eradicate all PICU out of area placements with that new model and estate as well. And we're also continuing to be in negotiation with the South Bank Navigo on that plan too, because that should eradicate out of areas for the North Bank and the South Bank, which is great. On older peoples, that's the other group that we're placing out of area. We similarly have a plan for that as well. Additional step down, step up beds that I've reported in my report. Again, the assumption is with that and expanding the wider community out of hospital services, we will eradicate older peoples this year as well. So I think there's reasons to be hopeful for both of those pieces. But collaborative work and looking at models that we're applying across the rest of our system is always helpful, and that has helped us produce our model and our plan as well.
Right then, no other questions are hands up. So thank you very much, Alison, for that. Can I just, when you do the reports, obviously from the last time you do them, do you know, so for example, on the Oliver McGowan, it says delivery has started in 11 out of 14 health and care organisations and over 3,600 member staff completed. Do you update that every time? So we've got a comparison where we were the last time we had the report.
We can do that for future reports, yeah.
I just think I think on some of this, it would just be good to see a little bit more progress.
Yeah.
Because I don't know whether that was something was in, I'm trying to think if that was in the same report 6 months ago and it's not moved on, if you see what I mean.
No,
Yeah.
Happy to do that. I think what we do, Caroline, is sort of give a spotlight on the initiatives and
Yeah.
that we're working on.
No,
and
I
the programs,
appreciate that.
but yeah, happy to do that.
Yeah, I think in some of these areas, it might be helpful just to sort of know where we're moving forward on or not.
Yes.
Brilliant. Thanks very much, Alison, for
Thank
that.
you.
Appreciate
Thanks,
that.
everybody.
Thank you very much. Great. Move on to the finance report. Pete.
Thanks, Caroline. So I'll try and be brief because the finance report's very similar to what we've seen at the board previously. So at a system level, the system are continuing to forecast a 93 million deficit by the end of the financial year, and that is pretty much consistent with what they've been doing throughout the whole of Q4. As a trust, we are continuing to forecast a 3 million surplus, and I think we've been doing that since December time. Yeah, and again, consistent with previous months, and we know that's due to the non-recurrent income received in year. Our cash balance in the report, the eagle-eyed folk will see it's actually a little bit higher than it normally is, and that's primarily due to the timing of salary payments and the fact that February is a 28-day month, and usually the cash comes out of the bank the day after. But I also think within the report, it is worth mentioning the mental health division and the much improved forecast we've got there, and that's a credit to all the work that's been done for the targeted intervention and by the division themselves. So I'll stop there, Caroline. I'm happy to take any questions.
Thanks very much. And I think on behalf of the board, just thanks to all your team who've been involved in huge amounts of work and continue to be involved in huge amounts of work, but particularly in the last 6 months, it's been very full on, I know. So I'll extend our thanks to them. Kath.
Yeah, thanks. In the context of that strong position, Pete, just a couple of questions cropped up when I was reading the report. So just in the mental health division where we talked about an underspend, there's a note around the staffing remaining at levels lower than the first half of the financial year due to improved roster management and control processes. So is that something we're taking forward for budget planning for 26-27? That's a kind of a sustained improvement while still maintaining our safe staffing levels. That's how I'm reading it.
Yeah, I think that's correct, Kath. We'll continue that work in terms of living within our establishment levels, but maintaining a safer staffing rota. And I can see Lynn's nodding, so.
That's good to know. And a second one, Chair, if that's all right, once again, a sort of a minor query, just on the agency. And I know we've got some great, some data in other reports that are showing improved agency, and I think it's the comment and really around consultants, and obviously I'm still pulling the newbie card around some of my questions that I'm asking, but I know Kwame had talked to us about some recruitment. I think it was probably cropped up at the development day last month, so I was just wondering, when we've mapped in that recruitment that's already happened, have we still got consultant level gaps that we are, the hard to fill gaps, or have that moved us to a much better position and we've not got those concerns?
Kwame, do you want to answer or do you want me to cover?
Yes, I thank you for the question. I think we've made a lot of progress with consultant recruitment. I think we started with quite a massive amount of vacancies, around 35-37%, and we're moving rapidly closer to single figures. We still have a few areas where we need to double our effort, but we have had new consultant who started just the last couple of months, and those figures will come through. I mean, Caroline and Michelle are aware of how many interviews we've been doing over the last few months and things to recruit people. So position is much better, but there's a few areas that we need to, our stretch target for this year is to make sure we get to a position where we are close to zero of using agency consultant.
I think in the performance report, I think it shows the vacancy rate around 20%, if I remember from that slide. So I suppose
it does,
just
Caroline, yeah.
Is that right?
At 20, yeah.
Yeah. How many? What is 20%? That's 20% of 100%, obviously. But how many people is that? How many consultants is that?
So with our numbers, 20%, we are about 50 consultants. So we're talking about 10. but
Okay.
the figures would come through. Some of the figures from those who just started reading from the last 2 months haven't come through the ledger. We are aware of that. It takes some time for it to come through the ledger.
Okay. Okay.
I think it's just trying to get a sense, isn't it, of what the gap look like now we've done the consultant recruitment, and if there's any that was really hard to fill because of national issues or local issues, is there an alternative workforce model for us to consider to carry on working on rather than going out to recruitment and then recruitment and not appointing. So it was just trying to get a sense of, have we got our arms around that gap, if you like.
Yeah, I'm happy to give you that report. I do send a regular report to EMT and OD committee, and we do skill mix. We use SAS doctors in areas where it is appropriate. There are some areas such as inpatient where you need an AC status and a consultant, where it is difficult to put somebody who have less qualification because of CQC and regulation. But we're doing everything we can, and I suspect 2025, 26, 27, our stretch target is to eliminate use of agency.
Okay, thank you.
Okay. Michelle, did you want to come in? Did I see your hand up go up then?
Well, I'm okay. I mean, it was really what Kwame said. It's a really good question, Kath, and I think something we always look at is skill mix and how we can use advanced practitioners and what have you. So we are always testing the bar on that. But just to really come in, Kwame, anyway, because we've done really well actually, Kath. I mean, I know we've got a lot of work still to do, but we've done quite well really with the ones that we've been recruiting to. But yeah, we do that checks and balances constantly around can we look at different practitioners and different skill sets in relationship to what we've got for all our practitioners, but particularly the consultants. So it's a good point, and we need to keep appreciatively challenging ourselves on that. So thanks.
Yeah, maybe it'd be quite nice, Kwame, just because obviously I'm sit on these interviews with Michelle, and obviously I feel like I'm always at the positive end of seeing people and being able to, at the end of it, with my other panel members saying we've got appointable candidates here who we would like to work with us. Maybe there's something about, I don't know, just I don't want to give you much, but just as very simple sort of just maybe a little table to show maybe where we were our recruitment successes and where it sort of leaves us, because then I think people might see some of that progress as well as the very valid point Kath made about design and of these jobs and who could do them and what have you. Michelle.
Yeah, that's a really good point. But just to reassure you, this is a bit of reassurance, Kath. And as Caroline said, we don't always appoint because we have had some panels, and I think this can be a bit of a rarity because people just tend to appoint. We don't actually. We have not appointed on a couple of the panels. So that's just to give you a bit of reassurance that it's about what we need for the organisation, the quality, etc., rather than just. So I think you know what I'm saying. But yeah, we can do that. We can do that, Caroline. Thanks.
Yeah. Great, lovely. Fine, thank you. If there's nothing more, Pete has survived a power cut in the middle of all that and come back to us. So you're welcome back, Pete. Right, okay, in that case, I think we can move on to the performance report. Lynn and Pete.
Lovely, thank you, Caroline. So this is the performance report as at the end of February. Again, very similar performance and pattern of performance. So we continue to see positive performance across a number of our workforce metrics like vacancies, Statman training, clinical supervision. We know sickness is an area of focus, and potentially we're seeing a few green shoots there. Let's not run before we can walk. Equally, some of our operational targets, we've seen an improvement in 52-week waits, excluding neuro, and our performance on CPA and EIP continues to be really strong. As an exec, we're currently reviewing performance report as we do every year at this time, and then we'll be looking to bring a proposal to the board, the strategic board, in February about changes to the report in terms of content and format. And that'll probably take on board things like the operating plan submission we've just done, the national oversight framework, and anything else that comes out. So I will stop there and invite any of my exec colleagues to add anything. I'll go straight to questions, Caroline.
Okay, any other exec colleagues would like to add anything? No, we'll go straight to questions or comments, please. Phil, first.
Yeah, no, it was a really good report with some looking at some improvements in some areas that we struggled for a while. Just on a positive, I'd like to highlight the fact that liaison psychiatry 1 hour response times, we struggled with that for quite a while, but it's now above our target of 80%. There's still a little way to go. It's not as good as it was in 2024. But that's really good news because that one's been slightly puzzling, but it's showing signs of improvement. Just the nature of these things, a couple of areas that I'd just like to ask what's happening with the delays at transfers of care for adult and older people, mental health. That's above the upper control level for the first time. That's on page 221 of the report. And there's a couple of areas where activity is not where we're asked to be. So UCR referrals are sort of 50% down against target, and the perinatal access remains low. But overall, it's a really good report with some really good news. But for a time, I haven't mentioned all the good things, so I apologise for that.
Thanks, Phil. Anybody would like to come back to Phil on the points he's raising around particularly UCR and perinatal? I think we've been through the perinatal stuff before. There's considerable work going on, I think, in that space. Lynn.
I'll just pick up the UCR referrals first, Phil, if that's okay, because we are obviously concerned about that. But obviously the referrals come from other agencies on the patch. So what we can do to control that is make sure every agency, including the ambulance service, the acute hospital, primary care, understand, what is suitable for referral to the crisis community service, and that they understand the referral pathways. We have done everything we can to make those as simple as possible. But you're right, over the last couple of months, there has been a deterioration. So we're picking that up with the North Yorkshire system as a whole as well, to ask our system partners about what's going on with that. Is it that there just has been fewer suitable referrals and demand has reduced over the last 2 months? And there is some evidence to support that, actually, demand has reduced. However, we do want to see that optimised, and obviously it is reported. So, but I can assure you we're doing everything we possibly can to address that. On perinatal access, it's not dissimilar actually. So again, it requires our service to receive the referrals and from elsewhere as well, the other agencies, maternity services, again, primary care, even mainstream mental health services, CMHT. So what we have done is a significant campaign around raising awareness. And obviously that's been a lot in the national media lately, hasn't it, around access to perinatal services. Mother and baby units have been part of that. So again, we're doing everything that we can. We do have a plan to optimise that above the target. As best as we're able to, but we do know these access targets are being looked at nationally as well at the minute to see if they have been actually placed at the right point. Are they over ambitious, I guess, is the question that everybody is asking themselves. So again, we've done everything we can to make sure that we are easy to access. We've done social media campaigns, for example. Patients can self-refer as well. So we have opened up every route to referral that we possibly can around that service. So we are working hard on it, but it is interesting it's being picked up nationally as well. Sorry, have I covered all of your areas? Was there another one?
I think so.
It's about the delayed transfer of care.
Delayed transfers, yeah. I guess that goes.
Older people, yeah.
We have seen that rise in older people's delays, unfortunately. Again, through that MAID approach that I explained earlier, we have been focusing on those older people delays. Actually have seen the most recent report, it has reduced a bit again as well, which you'll see obviously in next time's report when you see it too, suggesting that some of those escalations have improved as well. But no surprise, that's been a system pressure through winter, particularly around older people's. So, but obviously we are doing everything we can, Phil, to reduce it. The last group of patients we want to see delayed, obviously, is older people, but they are often in that position when they're accessing 24/7 residential type care. And obviously it's availability of those types of placements, specifically when they are bespoke placements as well, which they often are for the service users that are admitted to hospital. We are escalating it in the appropriate way. We are raising it on the system calls, etc. Our position is really transparent around that. We're working really closely with the local authorities and escalating those where they need to be. But I am pleased it has reduced since this report. But however, we're monitoring it very closely.
Thank you.
Thanks very much, Kath.
Hi, thank you. Yeah, just a quick question on the goal 1 and the SPC charts in relation to the incidents for forensics. Unfortunately, my graph goes off, so I can't quite see where it gets to. But I guess when we're looking at SPC charts, we kind of say 6 or more of a trend. It would trigger some kind of review of your upper and lower control limits to see what's going on in that service, if anything has changed. Looks like there's been a few upward trends in forensics, and I think when Karen answered my question around the staff survey and teams and services that were slightly away from the trust national average, I think you also mentioned forensics. So when you were talking about triangulation, is this what you'd look at, would be the number of incidents as well as the staff surveys, just to try and see if there's anything else going on in there that we need to be aware of?
Who's going to deal with that? Sarah?
Yeah, happy to respond. So I think we do that triangulation. So as part of the incidents, we do that through QPAS, but also we really look at it through the accountability reviews as well, because that's where we'll be looking at those sort of staff survey results, and really we'll really see further analysis of what that incident data sort of profile looks like. For me, in forensics, what you tend to see is you can get peaks of incidents which relate to a particular patient. So what you may find, and this tends to be the trend for forensics, is you might see a group of 20 incidents which actually relate to one patient, and it's due to the the complexity of that patient, and that's very much a typical pattern for forensics. So yeah, so I don't think it's linked. I don't feel there's any correlation with staff survey. I just think that's down to patient group at that particular time.
Now that's helpful, and I attended the patient safety huddle, do we call it, run by Oliver and team a couple of weeks ago.
Yeah.
And I guess saw some of that in action as them reviewing. But obviously, what the SPC chart is designed to get us to ask the question, isn't it, and not jump to a conclusion, but ask the question it, and then sort of look at the data. So I was just raising it in that context. Thanks, Sarah.
Thanks, Kathleen.
I just wanted to add a little bit of context, particularly to forensics, Kath, because there has been deliberately some change in patient groups around forensics. With the advent of the community forensic service, patients that would have stayed in hospital sort of even a year, 2 years ago are now discharged, meaning the patient group that we have in hospital are the very acute complex, which is right. That's where we'd need them to be. I agree with everything that Sarah says, but actually an upward trend to some degree, we don't want to see that, but no surprise that we are seeing a bit of a change, which does reflect that patient group. So, and it does often mean that and obviously we do, as Sarah says, that sort of deep dive into who is it, and it often is sort of one or two. I know, for example, we've got a patient waiting for High Secure at the moment that's impacting the incident trend data, but we know that and we're managing that. And if you look at the Reducing Restrictive Interventions report, for example, it will give that sort of detailed narrative about what is going on when we see that sort of increase. Incidents sometimes do see that sort of increase in use of restrictive practices in the right way as well. So we do correlate across those reports as well to have a look at those. But the success of the community services for forensics, which is positive, has meant that sort of patients are staying in hospital, much reduced length of stay, which is really positive. But it does mean we've got a concentrated group of patients who are more acutely unwell as a group than they were previously.
Thanks very much for those comprehensive answers from Sarah and Lynn, and thanks for the question, Kath. I can't see anybody else's hands up, so we'll move on then to the risk register update. Sarah and Oliver.
Thank you, Chair. I'll pass straight to Oliver if that's okay, but obviously the report provides the risk rating of 15 plus, those high level risks for board to consider. But over to you, Oliver. Thank you.
Thanks, Sarah. Good afternoon, everybody. Obviously, just to introduce the report, obviously, as Sarah's indicated, it's the Trust-wide Risk Register summary as of current position, most recently reported to EMT and ODG earlier, well, February and early in March. Currently 4 entries that meet the scoring threshold for inclusion. So obviously with a current risk rating of 50 or above, so essentially our significant rated risks. We've included within the summary page of the report just a bit of a breakdown of the key actions and kind of a bit of an update on each of those key risks and where they're currently sitting. There's been a lot of discussion around the composition of the risk register, so obviously we'll continue to review that and we may well see some additions and some changes going into the next quarter. So obviously we keep it as live as we possibly can, regular updates through ODG and obviously updates to EMT as well. I think other key points just to note is around, we've had discussion linked to the primary care transfer project risk, which I think was previously highlighted at board. That risk has been re-reviewed. It does currently sit below the scoring threshold for inclusion, but just to give the assurance around what we're doing that linked to that risk, ongoing monitoring, regular reporting to ODG. Lynn is having sight of it via the Ops Director of Risk Register as well as divisional governance arrangements. So should there be any change or any requirement to escalate and rescore that risk, we've got the appropriate mechanisms in place for that. So just as another update there. In terms of the update discussed via EMT, I think there was good discussion around the actions linked to each of these risks. And obviously we do have a clear plan to take those risks forward. We're also going to be taking through regular review via ODG, particularly from a divisional focus, but as well for the Directorate of Risk Registers, any risks that have been on the register for 2 or more years, just in terms of where they sit currently, do they need to be rescoped? Has the risk moved on? And additionally, just looking at some more arrangements linked to any risks that have been static over a 6-month period, just to further strengthen our review arrangements, make sure that the risk register is as current as it can be. In terms of closed and de-escalated risks from the Trust-wide Risk Register, nothing to highlight since we last reported to November board, but I do anticipate some changes going into Q4 reporting. And in terms of the wider risk register, we're currently sitting as 157 risks across the Trust Risk Registers, which was a change from 11, or a gain of 11 risks from the 146 reported to board in November. However, that's not just simply 11 additional risks, we've had a number of closed risks as well. And obviously we continue to monitor the changes of risk registers with new entries, risks for escalation to EMT and risks that have been closed in month via ODG and to EMT as well. So happy to take any questions on the content, anything we need to consider going into Q4 reporting. Welcome any feedback.
Any questions from board? I've got a sort of question. If other people want to come in, and it might not be for you, Oliver, it might be maybe for Michelle, and maybe it's just me wishful thinking, to be honest. But given, obviously, we've got a number of risks associated with the system and the ICS and everything. I just wondered about, given that we're coming to a point now where the ICS, in terms of what it's been doing in terms of its structure and shape, its staffing, that coming through, and Michelle, this might be for you really. And also we've been through this whole process recently around obviously our budgets and plans, medium-term planning. Whilst, do you think there's anything within that which will for us stabilise to a certain extent or be clear about where we stand in order us to maybe to look at those risks surrounding that in terms of how it's weighted?
Yeah, I think when we're going to April, we'll have a better viewpoint of what the ICB board looks like, what regional office board looks like. Obviously, it's a bit scanty coming through region at the moment, but I think I've asked Oliver to have a more forensic review of the ICB board risk register, and then I'll meet up with Oliver probably when I come back off leave, just to maybe have a look at how the system is. We'll probably have some more information on what's happening with the plans, because as you know, we've submitted a second plan as everybody else has. And also I think we'll have more clarity on what's happening with the segmentation 5 hospitals, Hull and NLAG. Because at the moment we just know that they've gone into the improvement recovery programme. We're not quite sure what that entails yet. There's also some talk about some more work being done with the ICB on their finance piece, which I'll pick up a little bit later. And so I think once we get all that a bit more clarified, hopefully in the next few weeks as we get into this new year, we can then probably reassess it at that point. And I think that's what that's what I've articulated. But I also want to understand the ICB's risks as well, because then we can compare. And obviously I see them being on the ICB board, but I think there's still a bit of a gap there. But I hope that's useful, but it is in sight. I have got it on the register. I just thought I'll just leave it a bit to try and see if things can settle down a little bit and then pick it up when I come back off leave, if that's okay.
Yeah, thanks. I think it's just as we get to be clearer, the smoke clears to a certain extent, for want of a better phrase. We might, you know, what we don't know is the hardest thing, isn't it? But when we do know, even though there'll be risks with it, we can maybe that be a helpful conversation. Okay, great. I can't see any other hands up, so we'll move on to the BAF.
Yeah, thank you. So in terms of the Bull Assurance Framework, obviously that represents the iteration for Q3. As ever, it's been through each of the board committees for appropriate level of review, and we've taken on board comments and some slight amendments. In quarter as well, we've received our annual audit of the Board Assurance Framework, in which we've received significant assurance. It has set us some recommendations and some clear actions around further developing the document, which we will be going live with for the Q4 version, more around just getting a bit more succinct and being really clear in terms of changes in quarter. So those will be coming around for the next version of the template. In terms of the sort of changes that were made for this version, we did some more work around the particular mapping of the inputs and outputs for the positive assurance, as well as the gaps linked to the actions, hopefully to make it a little bit more useful and easy to kind of link the relevant sections together. So I think we've had some good feedback around the document. As ever, you know, happy to take any further comments at this stage. Obviously, we've kind of come to the end of the process for the quarter, so obviously had a lot of feedback, as I mentioned, through the committee. So just if there's any questions, any considerations we need to give as we're developing the Q4 version, but just to give you that assurance that obviously we will be further developing that in line with the outcome of the audit, which I think was overall quite positive, and I think giving us some good areas to focus on as we continue to develop that document going forward.
Thanks for that, Oliver. We'll be obviously got an item in part 2 to look at the audit work. I think it was positive. I think all the areas they picked up for improvements were pretty much on point, actually. I think we know that, don't we? So that was good to see that affirmed in some ways. Great. Phil.
Yeah, Oliver, you'll be aware of this, but at the next quality committee, we're having a deep dive look at enhancing prevention, wellbeing and recovery. I think that's currently the highest rated of our 6 strategic goals, and we'll be having a close look at whether the actions speak directly to the strategic objectives, because at first look there's lots of actions, but then you scratch your head thinking how do they actually meet the strategic goals. So I think that will be our focus, and whether there are any that are not on that should be on.
Great. Thank you for that update, Sarah.
And it was just to say that as exec directors, there'll be a really thorough review of the BAF in light with the recommendations from the audit as well. So myself, Kwame and Lynn have already got a meeting in to do sort of some of that review, Phil. So just so you're aware, that might fall out with the timings for quality committee, but there is a piece of focus work plan just for your assurance as well.
Okay, thank you very much. I can't see any other hands up. Thanks, Oliver. Great. Right then, we move on then to the Assurance Committee reports. We'll go through those. Let me just get them right. Obviously, Dean did author the last one from the People and Organisational Development Committee. I don't know if anybody else from that committee or Karen would like to add anything to Dean's last report. Phil, are you doing it? Phil, are you doing it?
Been asked to formally substitute, come off the bench for.
Perfect.
Yeah. So the meeting was focused on some key strategic issues. Particularly, there was significant focus on sickness absence, and that came up several times. We also had a critical look at whether the wellbeing support delivered impact for the staff, and also, interestingly, for the trust as well, whether that delivered some of the aims that we were looking for. And we also were told that nationally the ESR was due to be replaced with a national solution, and that transition expects to take quite a long time and be complex. We received lots of good positive assurance. Our EDI indicators are increasing. There was a good resident doctors 10-point plan with very few remaining issues, and most of those issues requiring NHS England to sort out their side of things. With workforce benchmarking, the trust was performing well compared to peers, and we also heard from the Guardian of Safe Working, and there were no issues raised there. So overall, a good, reassuring meeting. Happy to take any questions or ask Karen to answer them for me.
Karen, when's the next scheduled meeting?
Off the top of my head, I want to say the 6th of May, Caroline.
Sorry, I wasn't trying to give you a trick question there. I'm just thinking about, obviously, we're onboarding hopefully a new, new non-executive director, and just thinking about how that lined up with that person maybe coming in and chairing this committee. Okay. May. We've probably got enough time then.
Yeah, it's the 6th of May.
Brilliant. Okay. Any questions to Phil? No. Steph, mental health ledge.
Thanks, Caroline. Nothing major to report on activity or restrictive practices improvement, all as expected, and really good work going on there. On the insight report, just to note that we will keep abreast of the Mental Health Act changes as the project plan develops and as the project team get underway with that. It's a long-term piece of work that will come onto our agenda. And just to reinforce a section of the Chief Exec's report around MAPA, the multi-agency protection arrangements, we had a audit that's taken place as a result of switching to the new System 1, and work that's continues to go on around there, and we will continue to keep MAPA on our agenda. And that is it from me.
Thank you very much. Any questions to Steph? No. We'll move to Kath for Audit Committee.
Thanks, Chair. And obviously this was my first audit committee with the Trust, so thanks to Pete and his team who worked very hard to help prep me for that. So it was a reasonably straightforward meeting, and I won't repeat some of the detail. I just thought it might be useful to highlight some of the audit reports we looked at and the internal audit plan for this coming year, which was signed off. So we had good outcomes for the budget reduction strategy audit, and we discussed that at the February Strategic Board Development Day as well. That come up there. And also the service users' property and money had come up as significant assurance, and I'm aware from previous audits that is an improved position for the Trust, so that is also good to see. As you can imagine, we spent most of our time talking about the two audit reports that received less than significant assurance. So one was around discretionary spend, and the other one was around prescribing at discharge, both with limited assurance. So we got some assurance that actions are in place to address both of those audits, and indeed for the discretionary spend, I think we got reassurance that most of the actions were actually all already completed, and obviously that goes into a cycle of being followed up by our internal audit colleagues. I know when we discussed the prescribing at discharge audit, Michelle was keen to see that go back into the leadership team for further discussion and nailing down of those actions. So we agreed that would be a good idea. So moving on to the internal audit plan, which we signed off for this coming year, just to give you a flavour of some of the areas that are in there, and as you'd expect, the internal audit will look at risk management, the board assurance framework, again, notwithstanding the board assurance framework audit, as you've just heard, came out with significant assurance with some areas to improve on that. But obviously linked into the presentation we had from Sarah at last month's strategic board was around preparedness for well-led inspection. So internal audit are going to help us with that, those arrangements. And also the topical area which has come up on this board several times today is that clinically ready for discharge is also included in the internal audit plan. You'll have seen on the papers as well that sickness absence is a continued focus, and as part of that it's felt appropriate to include that in the internal audit plan for this coming year to give us that assurance that our control system is working as it should. And as you heard earlier on the board when Lynn presented around the EPR, we're going to get a piece of independent assurance on the implementation of EPR. So that kind of gives you a flavour of the kind of things that the executive leadership team and then audit committee signed off to go into the internal audit plan for 26-27. And I'll pause there and happy to take any questions.
Thanks, Kath. Any questions for Kath? No, thank you very much. Hope you enjoyed your first audit committee. Moving on to specialised provider collaborative meeting, Steph.
Thank you, Caroline. Yeah, we met on the 2nd of March. This is our group of 4 providers who are working with Humber as lead to deliver in areas of CAMHS, adult, secure and eating disorders. Just a few things to note. One is the positive feedback from NHS England in our Q3 contract monitoring meeting, which is really good. A lot of focus, identification of risks around clinically ready for discharge in CAMHS and adult secure. There's a lot of focus in those areas. And finally, just to reiterate, I think, as we said before, the really positive financial position that we're projecting to the end of the year. And I'm happy to take any questions.
Thank you very much. Steph, any questions? No? Okay, thank you very much for those assurance reports. Moving on to item 23. This is the sort of working agenda for our April Board Strategic Development meeting. Please note that it will be happening at the Maples in Beverley. We'll make sure there's a full address on the front sheet so you don't get lost and wonder where the hell it is. And of course, you know, because we're meeting in one of our building locations, we're going to be looking at staff who work in the vicinity to maybe join us for our usual sandwich lunch with staff. So that's something that's being worked on at the moment. But we've tried on the key issues for it. We've reflected, I think, what people have said. But if people think there's some better wording or something missing, please let us know in the meantime. We've got time to finesse it a little bit. But hopefully that's okay. Any questions? No? Okay. I haven't got any items to escalate or any other urgent business. So we move to review of the meeting. Any comments people want to make about whether we've focused on the right things, that there's been enough discussion by members and the papers were fitted the purpose that they were meant to achieve. Anything people want to say that they want more of or less of? Probably less of me.
I think it's been really focused today, Caroline, really relevant topics and really interesting topics as well. So thanks to the team for preparing that.
Thank you, Steph. Great. Okay, in that case, we can move on. That's closed. Can I suggest it is in 12:39? We meet back at 1:10 for part 2, so everybody gets a half an hour chance to recoup, refresh, and come back re-energized. Thanks very much, everybody. See you shortly.
Thanks
Bye.
all. See you soon. Bye.